Good morning. Can you take a picture now? Thank you. Thanks for coming, girlfriend. That's a true friend right there. She's our class act. Children's Colorado? Yes. In Denver.
Here, you people are giving me the presentation, so there's a clicker if I get it.
Okay, but I can use this.
Yeah, I mean, I have a little clicker if you'd like a little tiny clicker.
It's okay.
Yeah, that clicker won't, for sure, yeah, that clicker won't advance yours.
Okay, no worries. Where's the breakfast?
You know where the plate and breakfast was yesterday, at the Highlands? If you go right down here and go straight to the right, and then down the embankment there, it's called the Highlands.
Okay.
There's a
Oh, yeah.
gigantic breakfast set up there.
Nice.
Learn how to scavenge for food until they're a resident.
Oh, yeah.
You always know how to find it.
Sure. It was sort of funny, those house things where you would go and, they always deliver breakfast to the comatose people. And you walk in there and eat all their food, because they're comatose, they're not eating. You find food in the goofiest place, but it was always like terrible food. Well, I think we're gonna get started on time.
Okay.
I don't know where everybody else is, so. Are you guys ready? Yeah. You're up and running, right?
Ready to roll.
All right, well, I'm gonna get started, we're gonna get started, looks like it's like 6 a.m. or almost there. And, we have, this is our student session, the Distinguished Trainee Lecture Series. Obviously, we put in not just trainees, but also students into it. So we'll start off with Julie. You have like 8 minutes.
Okay.
And 2 minutes for questions.
Well, good morning. Thanks for being up bright and early with me. Before we get into it, I just wanted to say that before this year of research, I knew very little about retinopathy of prematurity. And I've since come to realize there is a huge need for both screeners and treaters of this disease. And so this is my shameless plug to the 2 fearless students in the audience right now, that this is a precious and very deserving population that you could potentially serve one day. So just something to think about. But let's get into the comparative outcomes of bevacizumab and aflibercept in the treatment of retinopathy of prematurity. These are my incredible mentors and the research team I worked with. Dr. Butterfield, as we speak, is taking her oral board, so praying for her. She's going to rock it. And this work was in part supported by a grant from Research to Prevent Blindness. So a little bit of background. What is retinopathy of prematurity? So retinal vascularization occurs in a relatively hypoxic environment, the mama's womb, and is not fully completed until about 40 weeks gestation. But, for example, at Children's Hospital in Colorado, babies are born as early as 22 weeks gestation. So this leads to the infants now completing their retinal vessel development outside of the womb in a hyperoxic environment. And it's really this increased exposure to oxygen that's driving this disease. And as you can imagine, if you're born super prematurely, you could have other comorbidities, including severe lung disease. So often you need supplemental oxygenation, further increasing your risk for ROP development. And when we talk about ROP, we use terms like zone, stage, and the presence or absence of plus. And broadly speaking, zone refers to location, where how far out did the vessels grow. Stage refers to characteristics of the ROP in the eye, and as you increase in stage, you increase in severity. And then the presence of plus means that those abnormally formed vessels in the eyes are very dilated and wiggly and could potentially tug and pull on the delicate retina and lead to a vision compromising complication like retinal detachment if not treated. So how do you treat ROP? Anti-VEGF intravitreal injections are commonly used. Bevacizumab is one of the more widely accessible and used agents, but recently aflibercept gained FDA approval for the indication of ROP, and it's the first anti-VEGF agent to receive FDA approval for this indication. There's also literature suggesting that aflibercept has less of a systemic anti-VEGF effect. So due to this, some ROP care providers are switching to using aflibercept as their first-line treatment for ROP, and that's what the providers at Children's Colorado did. So naturally, after the switch, you would want to ask, how does aflibercept compare to bevacizumab in the treatment of ROP? And to look into this, the team conducted a retrospective cohort review or chart review from 2006 to 2025 using data from Children's Colorado's ROP registry. And we subgrouped out babies who received treatment with bevacizumab for their ROP and those that received aflibercept for the treatment of their ROP. And we followed the babies at the time of first injection and 4 follow-up visits after. We looked at clinical outcomes like regression of disease, the need for retreatment, and the end vascularization status. We analyzed 53 infants and 105 eyes, and the demographics between the 2 cohorts were not statistically different. And we saw that both drugs effectively and consistently regressed disease, which was awesome to see. They did what they were out to do. The light green shade is signifying stage 3, so that moderate to severe ROP territory, and then the red line is plus disease. And you can see after injection, both decline. What was interesting, though, was what did differ in the babies that did need retreatment. The indications were different for those that received aflibercept. Usually retreatment was due to non-response. They received their anti-VEGF injection and their ROP never improved. Whereas bevacizumab, their retreatment was typically due to reactivation. So they received treatment, they improved, and then their disease reactivated. Why was this? The ROP care team got together to think about this question, and they hypothesized that the non-response trend seen in the aflibercept cohort could simply be due to drug loss or not enough medication getting into the eye. As you can see in the picture, we're talking about very small volumes of liquid, and every amount matters. And essentially, the aflibercept dosage was half that of the bevacizumabs, but it was the dosage used in the FDA trials for FDA approval of this drug for ROP. So this led to a transition toward higher volume microdosing techniques to improve delivery consistently. And so they essentially doubled the dose, and they started using a smaller micro syringe. And this was a recent implementation, but we have seen a decrease in the aflibercept retreatment rates, and we're excited for the long-term outcomes and to look at the data and see what it tells us. But in conclusion, bevacizumab and aflibercept are both effective at inducing regression in ROP. There was no difference seen in the retreatment rates between the two drugs, but if retreatment was needed in the aflibercept cohort, it was more likely due to non-response and occurred earlier. And thank you so much for listening.
I have one question. Now, I know, actually, you said it was recently approved. I think it was approved within the last couple of years.
2023
Yeah, 2023, aflibercept, for this particular indication.
for ROP, correct.
For ROP, that's been around obviously longer. Does anybody know if any other drugs were approved for ROP? Yeah, for ROP, other than aflibercept. I was just curious because I don't know. Do you know?
There's not.
There is not. Okay. That's
So essentially, bevacizumab, which is widely used for ROP treatment, is off-label use.
right. Yeah, that's right. You know the brand name for it?
Avastin.
The brand name for the aflibercept.
Oh, Eylea.
Yeah. All right. Thank you.
Thank you.
There's Eylea HD now, but is Eylea HD a different concentration or?
Thanks. Sure. Thank you. Most people just call me Sam. Like I said, I'm a PGY1 ophthalmology resident at Henry Ford Warren, and I'll be discussing a case of interesting case of optic disc edema for you guys this morning. And so, a 62-year-old male presented to our resident clinic with a 2-week history of blurry vision in his right eye. His past medical history is listed there. He has type 2 diabetes that is non-insulin dependent. Ocular history, he has glaucoma suspect in both of his eyes, as well as a history of posterior vitreous detachment. He had LASIK about a decade ago, unsure of the exact timeline. His medications are listed there, and he has no known drug allergies. And so when he first presented, his vision was 20/60 in the right eye. Other vitals were unremarkable. Anterior exam, he had some nuclear sclerotic cortical changes, myobian gland dysfunction in both eyes. Other than that, unremarkable. However, his fundus exam, he was noted to have blurred margins, blurred disc margins inferiorly and temporally, as well as subfoveal subretinal fluid and intraretinal fluid versus schisis that appeared to track towards the optic nerve. And you can see with his OCT MAC, I mean, for the medical students really quickly, the OCT MAC in that red square, it's a thickness map. It's red is thick, and you can see from the macula and the fovea, it appears to be thick and tracking towards the optic nerve on the right where that arrow is in the papillomacular bundle. And then this arrow just kind of demonstrates the subfoveal subretinal fluid that he had on his first visit as well. And this is just a higher definition OCT of his macula, again demonstrating the intraretinal and the subretinal fluid. And then this was his OCT of his optic disc, again, red square, heat thickness map. You can appreciate that it's significantly thicker, as well as the RNFL in the right eye compared to the left. And then this on the left was his fundus photograph. I can kind of appreciate the blurred margins temporally and a little bit inferiorly as well. And I just included the OCT of his optic nerve to demonstrate where the scan picked up that. And so at this point, the plan for him was to return in a week on our retina day for a review of his FA and then a repeat fundus exam. So this is his FA. As I click through the slides, you can appreciate the optic disc becoming more hyperfluorescent, as well as fluid tracking or leaking peripapillary as well in that red arrow. And so at his second visit, vision worsened from 2060 to 2200. And after we investigated his medical history closer, he denied any sort of steroid use. As far as his intramuscular testosterone, per chart review, that was started or prescribed in August of 2023, but then that was discontinued in February 2025, so almost a year before he presented to us. However, in January of this past year, he did have a recent travel history to Bangladesh for about 10 days. He denied any cat exposure and denied intravenous drug use as well. Despite his vision worsening from 2060 to 2200, his intraretinal and subretinal fluid improved markedly. The scan is from his second visit on the left compared to his first visit on the right. Again, this is a 21 line, just a higher definition image. And so at this point, our differential diagnosis included diabetic versus hypertensive papillitis, some sort of infectious versus ischemic versus inflammatory optic neuropathy, or some sort of underlying neural retinitis. So the patient was sent to the ED for labs and imaging, largely unremarkable as far as the CBC and CMP. He did meet the age for GCA criteria, so we got a CRP ESR, which is unremarkable, and his hemoglobin A1C was 5.8%. His imaging, chest x-ray, and then head and neck were all negative. However, his micro resulted in a quantiferin TB positive. The rest of his micro was negative. We did a lumbar puncture, IR was consulted. CSF culture did not grow any acid fast bacilli. So everything was negative other than his TB test, essentially. And so after a 5-day admission, he was discharged with full ripe therapy per infectious disease, followed up outpatient, and that was de-escalated to rifampin and isoniazid. And when we saw him a couple weeks later for his third visit, his vision improved from 2060 back to where his initial presentation was at 2060. And then this is his third scan, OCT MAC, demonstrating almost near resolution of his intraretinal and subretinal fluid. And then this is the OCT of his optic nerve as well, just showing significant improvement of his disc edema. And then that's it. Any questions?
Any questions?
So obviously, like TB was the culprit here, right?
For the yeah.
Can you repeat the question?
Oh, I'm sorry. The question was asked, was TB the culprit?
So can you go back to the slide of the drugs that were there to treat him?
Mm-hmm. Oh, the TB drug, sure, yeah.
TB drugs. So do any of those drugs bother you at all with someone who has optic nerve pathology?
Yeah, the ethambutol bothered me quite a bit, especially when, and even the isoniazid. The AAO guidelines, I think, state that you need to have 24-2. I forget how often, but the ethambutol for sure in underlying optic neuropathy.
It's kind of a double-edged sword in this patient because they needed to treat the TB.
Right.
It can be extremely toxic to the optic nerve.
For sure.
And I've definitely seen a few cases, not many, but it can wipe out an optic nerve just like that. And I'm
Yeah,
This is kind of interesting. The treatment is now incredibly
for sure. And even with CNS involvement of TB in up to date, um, is not in our guidelines, but any sort of CNS involvement of TB, including the eyes, requires 12 months of ripe therapy, which, like you pointed to, can be really detrimental to the optic nerve, especially when they're on ethambutol for that long. So that is an area of, future investigation in terms of what the exact regimen and how long they should be treated for. Um, so yeah, I ID started them on ripe therapy and then adjusted them to latent, which just includes isoniazid and rifampin. And then with the isoniazid, you can get vitamin B6. Obviously, we learned that in medical school, but that's for peripheral neuropathy. I'm not sure what that entails for optic neuropathy as well. So an interesting point to consider in the future for sure in cases like this.
So I do also have a question. My question is, and I missed it, and I apologize.
Hmm?
But what was the final diagnosis? I mean, I know it's TB, but did you call it neuroretinitis?
Yeah, so the question, what was the final diagnosis? Yeah, we called it neuroretinitis, TB-related
It
op.
was in the slide, I missed it.
I actually didn't include it, so I apologize, yeah.
That's why I'm.
Yeah, no.
But it looked just like the typical neuroretinitis.
For sure.
Those are very impressive little lines in the retina too.
Mm.
I thought maybe you had AI enhanced them
Oh, no, I know.
they were real.
Dr. Scorn, I couldn't even turn on the mic. I don't know if I could do AI. Yeah.
All right. Well, are there any other questions? Well, thank you.
All right, thanks, guys.
Yes, sir. Yeah. Yes, Dr. Scarlett. Okay. Just going to put my timer on. All right. All right. Good morning, everyone. Today I'm going to be, actually, where's my clicker? Is this the clicker? Oh, okay. Hi, everyone. Today we're going to be presenting on IPL response in ocular rosacea and determining if imaging and doxycycline as a pretreatment is effective. Okay. How do we do this? Green bud. Thank you. Okay, so starting off, what is ocular rosacea? It affects approximately 5% of the global population. It's characterized by the meibomian gland dysfunction, which leads to evaporative dry eye and tear film instability. There's lid margin telangiectasia, and there's chronic ocular surface inflammation as well. And then patients usually have symptoms such as redness, irritation, photophobia, and blurred vision. Okay, so this is a picture of it. It's basically using intense pulse light. Typically, it's about 500 to 1200 nanometers. The sweet spot is about 500 to 700. That's where it's most effective at reaching the melanin. Okay, so how does it work again? So there's broad spectrum pulse light. It's absorbed by the cells there, and then it leads to, then there's heat. Absorbed light generates within the abnormal vessels, and you have the photocoagulation, and then there's the inflammatory reduction where there's a decrease in those mediators, and then that's how you get the gland recovery in the meibomian gland. Okay, so the clinical gap for this presentation is combination therapy of this pulsed light and doxycycline. It achieved a response rate as high as 90%, but the outcomes were pretty inconsistent. Some patients responded poorly or not at all across different patient populations. Preoperative meibographic features were shown to correlate with positive treatment response, but there was no validated framework for using this imaging as a pretreatment for determining the optimal candidate for this light therapy. And then the independent role of doxycycline pretreatment in modifying the imaging predicted outcome, it's never been studied. Okay, so for my methods section, it was a database pull. Those terms are there on your screen. Basically make sure it included preoperative imaging utilized for rosacea assessment. IPL outcomes had to be reported with doxycycline, and then we had a minimum of 3 months for the follow-up. Okay, so imaging predictors. Basically, we wanted more lid margin vascularity. That means there's more blood vessels for the IPL to work with. Gland plugging, this is a little bit intuitive, or counterintuitive, excuse me, because if it's more obstructed, then you know it's not atrophied, so that's better for the light therapy to work. And then if there's obviously more meibum present, then you know the gland's functioning. And then if it was atrophied, that's not a good response to treatment. Okay, so again, we had about a 90% response rate when it was combined. And then it was an 89% response rate when it was just monotherapy, so it's only 1%. It's not statistically significant. And then most of the research was heterogeneous study design, so it wasn't, you have to be cautious with the interpretations. And then no specific studies have examined whether doxycycline itself as a pretreatment to IPL modifies, again, that relationship between the imaging, the positive correlation between doing the imaging and the treatment outcomes. Okay, so essentially for IPL, it's imperative to do the meibographic imaging to see if that gland is even functioning. Because IPL acts on those vessels, we really need to make sure that there's actual functional gland tissue. And then the 1% with the doxycycline, that's again not really, that's not statistically significant. And again, most of those studies were heterogeneous. So, and then limitation-wise, most of them were also retrospective designs and again heterogeneous scoring systems. So it was pretty inconsistent. Okay, so just wrapping up here, no evidence-based framework exists for using, again, this preoperative imaging to guide physicians, ophthalmologists in using IPL for patient selection in ocular rosacea. Most of that graphing is done for just meibomian gland dysfunction as a whole. And then, again, with the plugging grade, you want a higher plugging grade and you want a lower gland dropout. Those are the strongest imaging predictors to IPL. And then again, that preserved lid margin vascularity, that's more likely to better show outcomes. And if the gland is atrophied, you're gonna have some resistance with that IPL. It's not gonna be the appropriate treatment. Okay, and my final slide here, just talk about future directions. I think what's really important is just determining a threshold for the candidacy, like how much of that gland do we need for that treatment to work, how much are we willing to accept of the atrophy, and then also integrating anterior segment OCTs with it to check the vasculature of the lid margin and of the periductal tissue. And then for future studies, just conduct prospective imaging stratified trials, examining that doxycycline pretreatment timing, and finally determining whether pretreatment, the doxycycline with its anti-inflammatory effect is going to positively impact the correlation between doing the imaging and then having the treatment work, because you know how much of that gland is remaining. So anyways, thank you for your time. Yes. Yeah. So, yeah, I gotta repeat it. Okay. Okay. So you were talking about if there was any symptom improvement with the one more time. Yeah. Yeah. Yes. Yes. Yeah. So the studies I looked at were primarily older populations, 60, 50s, 50s plus. With if your meibomian gland was more atrophied, the treatment wouldn't work. So they would still have the typical symptoms of the burning, stinging, irritation. So it the laser just it didn't improve the symptoms. Because that gland was so atrophied, the laser just wasn't going to work. It wasn't going to be effective at all. They were, and that's part of the inconsistency. Different studies had different ranges of like, okay, if there was complete symptom removal or if it was like partial. So it wasn't, that's why I said it was the studies were inconsistent. Also, they were heterogeneous because they were comparing so many different variables. No, they did. I did not find that. Yeah. 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 Any other? Yes. Yes. It's no. No. Exactly. Exactly. You need a functional gland to work on. Yeah. Any other? Okay.
But I do think it's a nice adjunct, and it's really good for rosacea, especially in mid-phase rosacea patients that are frustrated that, been on metronidazole for a long time. And I get referrals from dermatology to do it,
Mhm.
treat that.
Yeah. Cool. Any other questions? Okay. Good. Thank you.
Speaker is George. Did you ready? Yep. Okay, good, great. You got 8 minutes to present, 2 minutes for questions.
Sounds good. All righty. Can you guys hear me? Yes, perfect. All right. So my presentation is going to be on the history of ophthalmology. I see some medical students here in the audience and then some early residents here too. So I think the important thing with the history of ophthalmology, I'm going to focus on cataract surgery, is we kind of just jump into cataract surgery, kind of just taking everything we have for granted here. So hopefully we kind of learn some of the things of how we got here. So I'll start with this quote here. If you don't know where you come from, it's difficult to determine where you are. It's even more difficult to plan where you are going. So let's start with the history of the cataract and the lens. Cataract comes from the Latin word cataracta, which means waterfall, which was thought to describe the appearance of the white cataract. The first documented cataract was around 2500 BC. Really kind of the starts of any sort of advancements in cataract anatomy comes from an Indian physician, Susruta. He's credited with a bunch of early advancements of many ocular diseases. But then cataracts kind of got further developed, the anatomy of it, by a Roman physician named Celsus in 50 BC to 25 AD. He termed the name crystalline lens, which comes from the Greek word crystalloides. He believed the cataract was a disease of the aqueous humor descending down from the brain. You can see in this bottom picture here, this is his diagram of the eye, which is pretty impressive at that time to have a pretty accurate diagram. Number 2 is what he believed was the cornea. Number 1 was this aqueous humor. 5 is the lens. 6 is the vitreous. 4 is the choroid. So pretty impressive in 50 BC to 25 AD to have this accurate of an idea of the anatomy of the eye. And then another Greek physician named Galen discovered many anatomical parts of the eye. He wrote that the crystalline lens is the principal instrument of vision, a fact clearly proved by what physicians call cataracts, which is between the crystalline humor and comes to intervene with vision until they are couched. So we have some anatomy of the eye, but then how do we kind of view the eye and view the lens a little bit more? And Tony Van, I apologize, I'm going to botch a lot of these names, Louis Wenhoek, in the 17th century, made plenty of advancements on the lens. And he had a bunch of these quotes that really shaped kind of what we know as the lens today. I'll only go to the second one in the sake of time. But he examined a film or membrane enclosing the crystalline body and keeping it separated from the fluids which make up the further inner parts of the eye. I concluded that this membrane is necessary for the crystalline body in order to get that it gives it a perfectly round shape. So he's describing the lens capsule here. And then Hermann von Helmholtz, you'll hear that name a lot in the history of ophthalmology. In 1851, he invented the first ophthalmoscope to better view the eye and the lens itself. You can see in that top picture there a diagram of kind of the first ophthalmoscope. And then Alvar Goldstrand in 1911 invented the first slit lamp, which is that bottom picture there. All right, so our first real kind of cataract surgery we have here is couching. It kind of has a controversial origin, dating as far back as 1500 BC. Again, Susruta is kind of termed the father of cataract couching. It gained popularity once the Silk Road was established as well. This still remained a pretty popular surgical technique up until the 19th century, and still today is used in parts of the world in third world countries. What couching is an incision in the cornea with a sharp needle and dislodging the lens into the back of the vitreous. When Susruta was doing this, he documented that breast milk was used for a hemostatic agent, and then the eye was treated with ghee butter. So pretty crazy to think they were doing that. In 900 AD, Amar Ali invented a hollow needle to actually use suction with his mouth to extract the cataract. So pretty crazy, these early ideas of cataract surgery. And then we have to kind of fast forward to the 18th century, where something called an extracapsular cataract extraction was kind of first invented. It was by Jacques Daviel. He's the father of modern cataract surgery. And he made a larger than a 10 millimeter corneal incision to remove the lens. So, almost the entire diameter of the cornea to remove the lens here. Post-op care did involve dressings with cloths soaked in wine and lying in a dark room for multiple weeks. And then intracapsular cataract extraction was created because with extracapsular extraction, things like PCOs, other complications were involved. In 1753, an English surgeon named Samuel Sharp performed the first intracap, and again involved a large incision in removing the lens with the zonular fibers. The biggest complications were things like vitreous prolapse and retinal detachment, and it became it had a lot of complications as well. It was very inferior to extracap until about the 20th century. Many instruments were made to try to help extract this lens out of the eye. It included phacoeresis, which is another suction device, zonulysis by alpha-chromatrypsin, and then my kind of favorite, what you can see in this diagram here, is cryoextraction. So this is a cryo probe actually freezing the lens to this probe and extracting it out. I wanted to touch just real quick on M6 because this is kind of a pseudo form of extracap that does use a relatively smaller incision, a scleral tunnel incision, to remove the lens without the use of sutures. For the medical students and early on residents as well, this is still used in third world countries and if you go on like medical mission trips. I really just wanted to touch on two important stories here about the history of ophthalmology. Sir Harold Ridley, he worked in London at Moorfields during World War II. His inspiration for an implantable lens came from actually a medical student telling him, "Don't you think it'd be interesting if we could put a clear lens in the eye?" He was treating an Air Force pilot named Gordon Mouse Cleaver, who during battle got part of his airplane windshield, which was made of PMMA, lodged in the eye. He was no light perception, but Ridley noticed that there wasn't any inflammation in the eye with this intraocular foreign body, which kind of sparked his inspiration for the first IOL. This first IOL was a bioconvex lens you can see in that top right corner. His first attempt in 1949, he was so nervous he actually had to take it out of the eye. So the first successful surgery actually happened in February 8th, 1950. He quoted, "We must not fail to honor the two brave Londoners. To them, ophthalmology owes them a great debt." His secret actually was exposed. He wanted to keep this under wraps until one of his patients actually went to the wrong Dr. Ridley in London for a post-op, and then that's how his secret kind of got exposed. He faced a lot of criticism. His mentor, Sir Stuart Duke Elder, which was a famed ophthalmologist, really kind of was behind all of his criticism. They actually deemed these IOLs served better as IUDs. That was a quote from Duke Elder. It took until about 1980, so almost 30 years later, for FDA to actually approve the IOL. I have this signed that one of the actors in this show, Marcus Welby, MD, he was spoke in front of the FDA hearing to say that cataract surgery saved his vision and saved his career. And then kind of poetic justice, Harold Ridley underwent his own cataract surgery in 1989 and 1990. In the interest of time, this is just kind of how IOL advancements in either just making them small, foldable, and making multifocal lenses, things for smaller cataract surgery, kind of help advance cataract surgery. Here you can see just a timeline of all of our IOLs from that first one in 1950 with Harold Ridley all the way now to our light adjustable lenses, our EDOFs, things like that. The last story I kind of want to touch on is with Dr. Charles Kelman. He believed that small incisional cataract surgery was possible. He wanted to make a difference in ophthalmology. This was his avenue of making it. He got the idea for phacoemulsification actually when he went to the dentist's office and they used an ultrasonic instrument to clean teeth. He did his first phacoemulsification in 1967. He tested it on blind patients, but this didn't really gain popularity until foldable IOLs and OVDs were invented to kind of stabilize the anterior chamber. Nowadays, we use phaco with incisions as small as even smaller than 3 and smaller than 2 millimeters wide. That's the first phaco machine ever used, a little bit different than what we have now. So this was a one-handed procedure at the beginning, then bimanual techniques became more developed and things like divide and conquer, and then computer-controlled phacoemulsification to develop more precise energy. Now we're on to like a Alcon Unity 4D phaco, which allows for faster and less energy cataract extraction. And then just to look a little bit into the future, most advancements right now are in making cataract surgery like a truly refractive surgery. There's a kind of a push maybe for in-office cataract surgery as well. Machine learning algorithms to make more precise preoperative calculations, kind of in that refractive realm. Robotic-assisted surgery. This is Uday Devgan, a cataract coach. He did a cataract surgery off of the Da Vinci system. So pretty interesting things. And then, you know, maybe our biggest fear in ophthalmology, I guess, for on the surgery side is maybe drops to eliminate lens opacification. So I'll leave with this quote. It'd be any attendings out there what their thoughts are on kind of the future of cataract surgery or what you guys think. But thank you for your time. I know I went a little bit over here, but I appreciate it.
The first time I ever did an intracapsular cataract extraction was actually in 1992 when I went to Ukraine after the Soviet Union and the communist system fell apart. And they were still doing intracapsular cataract extractions without IOLs or iris of fixed
Yeah.
IOL.
Yeah.
And so they wanted, of course, at that time they said, you know, we want to, now that we're free, we want to be modernized. And they wanted to do phaco. And I said, I think we need to learn extra cap first. So I
Right.
learned extra cap, and then we went on to do phaco. Within a decade, they were cooking with phaco. But
Yeah.
it was very interesting. And I still remember one of my attendings using CryoPro
Really.
to remove. They always tell the saying, be careful, don't touch the CryoPro to the cornea or you'll pull the cornea off.
Yeah. Well,
And we use chymotrypsin. We
Yeah.
use chymotrypsin to eat away the zonules, and you go in with the CryoPro and, you know, sort of rock the lens around until we pull whatever was left of the zonules that you pull it out. It was, you know, so I guess I'm old.
yeah, I've had to be careful. One of my attendings, I used to say, like, back in the day, they used to do incisions of, like, greater than 10 millimeters, and he yelled at me, he's like, back in the day, I was doing 10 millimeters. So I'd be careful on how I phrase things. But do you have a question? Yeah.
In the late 70s, early 80s, the Tulsa Osteopathic Ophthalmology Residency, J. Harley Kalusha founded it, and he had ties to Europe. And so he was regularly going to Europe, and he was bringing back IOLs from Europe
No kidding.
in his patients' eyes in Oklahoma.
Wow. Yeah. Yeah. Very interesting.
Yeah, Harold Ridley actually, he did his first surgeries in the middle of the night.
Yeah.
Because they were gonna, they threatened to take away his all his privileges and all. And eventually he was knighted by the Queen. So
Yeah.
he's actually Sir Harold Ridley. And actually Kelman was the same way. The MD Society, AOA, American Academy of Ophthalmology, was gonna take away his board certification because he was working with phaco. And it just, and he used to be, he had a rock and roll record, a Kelman, that was in the 50s or early 60s, and his father went to him, you know, this may be a good career for you, but better have some sort of backup. And he said, well, what can I do just in case I don't make it in rock and roll? Oh, I'll be an ophthalmologist.
Yeah. Yeah.
Okay, thank you very much.
Yeah. Thank you, everyone.
Rock and roll and ophthalmology, they go hand in hand. Is there a Natalie here? Okay, well, Natalie, you lost your slot. All right, so I think the regular retina session starts here at 7, correct? Scott, yeah. So everybody has a break. You know that in Highland, if you
No, no, I'm hyped. I'm going on after him. I just wanted to see what the arrangement was. Not tall enough to see that over there.
I believe this microphone is on and running. We're just about a minute or two behind the top of the hour, so it's a good time to get started. So as you filter in, find a good seat and make sure you have a good view of our presentation slides here. I'm Dr. Scott Peterson. I practice medical retina out of Minneapolis area, and I'll be the moderator of this session. We'll begin with Dr. Andrew Strand. Dr. Strand completed his undergraduate and graduate studies with degrees in nutrition science and biostatistics at the University of Minnesota. He graduated from medical school at Des Moines University with an Excellence Award in the field of ophthalmology. He completed his intern year in ophthalmology residency at the Ohio University Doctors Hospital in 2017, followed by a surgical retina fellowship at the Retina Institute of California in Los Angeles. Dr. Strand currently practices at the Talley Eye Institute in Evansville, Indiana. Dr. Strand.
And on that note, since we have so many Minnesota connections here, just our introduction, as well as Dr. Petrie here, we do have to recognize that the trifecta did happen last night, a rare gem in Minnesota sports where the Wild, the T-Wolves, and the Twins all won games, so the stars were aligned for today. But I want to thank everyone for coming out early this morning, and I think we're going to try to spice some things up with a little bit of retina. I know usually this conference is more anterior heavy, and so I want to just welcome everyone here. Hope you're having a great time. I wanted to make this talk a little bit more fun and not didactic, so I have a bunch of videos and I have a bunch of surgical cases, and we'll have time for questions. And there's Joel walking in, another Minnesota connection. I love it. This is just Minnesota heavy here today. So let's jump right into it. So for conflicts of interest, I have no relevant conflicts for this talk. We're only going to briefly discuss methotrexate used off-label for the treatment of proliferative vitreoretinopathy, as well as TPA for the use of submacular hemorrhage. I am a paid consultant for Regeneron, but we're not discussing anything with their products today. So just as a general overview, we're going to try to jump right into PVR, but we're going to talk a little bit about the current state of retinal detachments in 2026, go over some trauma as it relates to the vitreoretinal surgeon's perspective, and then show you some blunders in submacular hemorrhage surgery. All right, so before we jump into PVR, I think we kind of need to take a step back and talk about where we are sitting with our current primary success rates with vitrectomy and scleral buckling over the last 30 years. So despite the fact that we have huge improvements in our technology, fluidics, instrumentation, and adjuvants, when you look at the literature, the over primary surgical success rate is reported anywhere from 75 to 95%. But I think the hardest part is when we look at literature, it's hard to get a truly accurate benchmark given the variability of published data that's out there. And mostly because this research is all retrospective in nature, and we have huge surgeon heterogeneity, as well as how people define their simple, complex, or difficult RD cases. So it makes apples and apples comparisons very, very difficult. Typically, as vitreoretinal surgeons, it's a great thing, just like cataract surgeons, anterior segment surgeons, to sit down and track your successes and failures. But I want to compare and contrast before we get into some videos and cases, just two different studies, and the first being an actual prospective randomized clinical trial out of Europe, and it was the scleral buckle versus primary vitrectomy for detachments. And this is where phakic or pseudophakic patients were actually randomized to a specific treatment, not the surgeon's preference. And we look back to 2007, and it's kind of strange to see in a randomized clinical control trial, if you look at the surgical success rates, this is kind of poor, right? Despite being phakic, pseudophakic, or a buckle or vitrectomy. But the other striking thing was the high rate of PVR, or proliferative vitreoretinopathy, which is the number one cause of surgical failure. So we jump forward here to the 2020s, and as a benchmark, something that we kind of use in our practice is the PRO studies. These were started to release in 2020, and it was a series of 3 published papers looking in a retrospective nature at surgical success for moderately complex retinal detachments.
However, it excluded young patients, any PVR, any prevalence of vitreous hemorrhage, epiretinal membranes, or large detachments. So you have to take all of this data, with a grain of salt. But when we look at these PROS studies, 3 of them, the first PROS 1 study was looking at a combined group of phakic and pseudophakic patients. PROS 2 was phakic only. And PROS 3 only included pseudophakic patients. And the key takeaways here from the PROS 1 is we see that we have very similar single surgery anatomical success rates with either scleral buckling alone, vitrectomy, or combined buckle and vitrectomy. It's only when we start looking at this retrospective data among like phakic patients only, and we see that a combined scleral buckle and vitrectomy or a scleral buckle alone being superior to a primary vitrectomy. The other thing to note is compared to the 2007 study we looked at is that these surgical success rates are reported as much higher, and probably a combination of this as it's being retrospective in nature. Finally, the PROS 3 study also showed that scleral buckle and vitrectomy to have significantly higher surgical success rates. And then of a final note, when we look at macular status or we look at the location of a detachment, we see a trend toward higher single surgery anatomical success rates with combined scleral buckling and vitrectomy. So if anyone here is a student and they're looking and going to vitreoretinal surgery, I think there's a huge role still to be played in buckling patients in 2026. But we talk about our number one enemy in vitreoretinal surgery, which is proliferative vitreoretinopathy, and it's the most common cause of failure after a primary retinal detachment repair, the other being missing holes, tears, or breaks. And it can occur in anywhere from 5 to 15% of cases, and basically you get the growth and migration of preretinal membranes, subretinal membranes, or even just the most feared intrinsic retinal foreshortening that can cause this retina to redetach. And it can happen in treated eyes, untreated eyes, someone who's had prior laser, prior retinopexy, or even just prolonged inflammation in the eye. And what makes it the bane of our existence is that once somebody develops PVR, they're more likely to develop PVR in the future, and these patients can tend to circle the drain without adequate intervention. And when we look at the primary success rate of these PVR detachment cases, the success rates are strikingly poor. And when we look at grade C PVR, meaning we've got fixed folds, star folds, or this intrinsic foreshortening, success rates can be anywhere from 40 to 85%, with the key that vision of better than 20/200 or greater is really only achieved in anywhere between a quarter to 2/3 of these cases. So overall, this PVR, it is a non-angiogenic fibrotic disease that's usually incited by a retinal break or liberation of RPE cells or a breakdown in the blood-retinal barrier. And what happens is a very similar process to wound healing, wherein we have an inflammatory phase, this proliferative phase, and tissue remodeling that leads to this fibrosis. And basically, these RPE cells undergo what's called EMT, or epithelial mesenchymal transition. And this EMT induces a myofibroblastic-like contraction of the retina, causing it to detach. And so if you see these patients or you've seen them in the clinic, you'll see this huge hyperreflectance on the retina. You can even see pigment clumping at the vitreous base, scrolled edges, tortuosity of the vessels, or a total retinal detachment. So overall risk factors here are: 1, having a prior surgery, having a larger detachment, more breaks, more tears, blood in the vitreous cavity, and other things that we know are likely to lead to worse success rates are patients with giant retinal tears or breaks that are greater than 3 clock hours, as well as other things like low vitamin D levels, smoking, choroidal hemorrhage, and even recently there's been published reports on patient consumption of marijuana leading to higher rates of PVR formation. The hard part is we really don't have much to prevent PVR. There's been a lot of research looking at everything from anti-VEGF agents, which don't work, steroids in any form. I've even tried to use isoretinoic acid. There was a buzz about that for a while. Our biggest hope was this GUARD trial, or using methotrexate as a course of intravitreal injections after surgery for these patients. However, the GUARD study deviated from its protocol so much, we really don't have much evidence to support it. Chris Reinman at the Cincinnati Eye and Ear, he's actually promoting studies right now of infusing methotrexate at the time of surgery. And then finally, as a surgical technique, it's becoming more common for us to prophylactically peel the internal limiting membrane, carrying that puppy as far into the periphery as we can over PVR to prevent scaffolding and reformation of PVR. So we're going to get to the videos and the fun in just a second. So when we get to intervention, we've got to permanently support this retina in any way possible to get that sucker reattached. So if we haven't had a buckle, we got to add a buckle. We got to peel all membranes, close all of the breaks, and even in the worst cases, perform large retinectomies. Sometimes we call ocular taxidermy. And then timing of these surgeries, obviously, if it's macula on, we got to get in right away, but these cases then can be more challenging in the sense that we have immature membranes, very hard to get off the retina, and typically if we have a PVR detachment that's macula off and we're still in an inflammatory phase, we'll sometimes delay surgery to make the surgery itself a little easier. So let's jump into some fun here. Going to go over some cases, and I know y'all in the middle here might have a harder time seeing the screen. But let's go over some cases. And so first one is a 59-year-old white male who was referred in for decreased vision. Patient had a history of a prior presumed pneumatic retinopexy with cryo and laser. Noticing a visual field defect. Vision is great at 20/25, but we'll go on here to show you what we're seeing. And we have an Optos photo of that right eye with otherwise clear media. And I don't know if you guys can see, but if you look there from roughly the 12 o'clock hour going all the way down to about that 8 o'clock hour, this patient has a retinal detachment. And if you focus up in that superior nasal quadrant, you can see this web of just subretinal bands diffusely. So on scleral depression, this guy had no breaks, holes, or tears, so it was presumed that this subretinal band or subretinal PVR was the source. And if you do look here closely at the OCT, I don't have the full raster, but we do see some subretinal fluid that's hanging out there, and so there was some fluid in the macula. So sign this guy up for a buckle and a vit, and we'll kind of go over briefly this case here. Can you roll that beautiful bean footage, Miles? So we've already placed the buckle here, as you can see, and doing a standard 25 gauge pars plane of vitrectomy here. And in a pseudophakic patient, I always want to remove that anterior hyaloid. So getting into the eye here, you can kind of see, this isn't the surgeon's view, but what you would be seeing looking into that eye, we see this diffuse sheet of these huge PVR membranes, doing a core vitrectomy, getting rid of all of the vitreous in this eye and checking for any other breaks. In these cases too, we've already put a buckle on, but we want to do a good peripheral shave. And so now our goal in this case is to attack this big, beefy membrane. And so I'm using diathermy right at the apex of this subretinal band. And what we're going to do here is called a punch-through retinectomy, where I'm going to use an ILM forceps. And sometimes you can pull these bands straight out of the retina. Other times you just break the band or lyse the band, like in this case, and you've relieved that traction. You can see the retina is much more hypermobile. And the other thing is you see this big boogery snot of subretinal fluid that we call sclerin coming out. And this is always satisfying when you're pulling this chronic subretinal fluid out of the eye. And so another pearl here for any young people trying to get into retina, try to reduce as much iatrogenic damage to the eye as possible. I actually had to create another drainage retinotomy. So you always frown upon yourself when you have to do that, but you have to do whatever you have to do to get the retina attached here. And then just another pearl, this is a case from way earlier in my career, and sometimes you start thinking that, well, more laser is going to be better to keep this thing attached. And so a little aggressive with the laser, but this patient overall ended up doing really well. We finished laser and then put in 24% SF6, which is a slightly expansile concentration of gas here. And so just finishing up lasering here, and then we do a fluid air exchange and put that gas in. And I've got one more video to show you here that's going to be coming up, and so that's just that gas exchange. But I wanted to show a satisfying video that you can see of pulling out a big beefy membrane from the back of the retina here, and we'll be prompted here with that. So a very similar case where someone had a detachment from a subretinal band, but I just wanted to show you how gratifying it can be to pull these suckers out of the back of the retina. And so just creating a retinotomy site, and then what we're going to go in with those ILM forceps here and just look at this big sucker coming out of there. Something that you could probably use in Minnesota to catch a walleye or two. Oh yeah, look at that. So overall, this patient ended up doing really well. This is about post-op day 10, patient staying attached. Because of the buckle, they had a myopic shift, and I think this patient got out to 3 months and just sent him back to optometry, and was roughly about 20/30. So often, if you have PVR just from subretinal bands, these can be easier cases. The more complex cases are when you have huge amounts of preretinal membranes and an intrinsic foreshortening. So I'm going to show you a little bit more of a complex case here where a Patient was sent in and they failed a primary surgery. I performed a scleral buccal and vitrectomy, prophylactically peeled the macula of the ILM, lasered them up 360, and just over a month out of surgery came back with a complete total RD, a very, very poor visual prognosis. So in this case, we're taking them back for a vitrectomy, peeling as many membranes as possible retinectomy, and then oil in. And so this video is a little bit displaced. And Miles, can you play this video here too for me? Thank you, buddy. And so we see here there's stretch holes at the site of prior laser, even possible laser necrosis, but you can see this sheen throughout the retina, and I'm staining here with ICG to kind of highlight any of these membranes. And we basically go in and try to peel all of this tissue off the retina as possible, and sometimes they can come off as nicer big sheets like this, peeling off the retina, but they're often very sticky and they can be prone to causing iatrogenic breaks. And so another pearl and pitfall in these cases is you always want to use every tool you have available to help you out. So in a case like this, I probably should have preferred putting PFO or fluoron in this eye to stabilize the retina as a third hand here more. Because what you're going to see is even these membranes here, we're going to start to make some iatrogenic breaks right here at the border of where this laser is. And so that's never a good sign. Oh, you're peeling. There's a big hole. And we continue peeling these broad, diffuse sheets, and so it can be very meticulous in these cases. Often, sometimes you're spending more than an hour in these eyes to try to save and salvage anything that you can. And as we continue to peel these membranes, we run into more difficulty of creating iatrogenic breaks and just really, really stiff, immobile retina. So at this point, we've deemed that this case is going to require a retinectomy here. And so what we're going to do here in a second is outline a retinectomy. And typically, we try to do about 180-degree retinectomy to get this retina attached. But the key thing I want to point out here is it's a pretty posterior retinectomy, but what we'll see is once we get this eye flattened with PFO, how much intrinsic foreshortening of the retina there truly, truly is here. Another pearl in these cases is you have to remove all of this residual retina in the periphery because one, it'll be a nidus for more PVR formation, also promote neovascularization and possibly shutdown of the ciliary body. And it gets hard in these cases too when there's already been a scleral buccal placed because you have retina that's just adherent to the buccal. So we're flattening this bad boy out here with PFO, and you'll see the retina completely flatten and attach, and then typically we add about 3 or 4 rows of dense laser for chorioretinal adhesion here. And once we start putting the oil in, you'll really see this stark contrast of where we initially marked that retinectomy site and how much foreshortened that retina is. Look at how posterior that marking is from where it originally was. And so this is why sometimes we call this ocular taxidermy in the sense that we're trying to do our best to get these retinas attached. And this patient, ended up remaining attached. I think we kept the oil in for roughly about 3 to 6 months and took oil out, but they only achieved vision of about, count fingers. So these are some of the most challenging cases besides diabetic tractional retinal detachments. And so just showing you a little bit of these tougher cases, and we'll jump right in here to trauma as it pertains to the vitreoretinal surgeon. And really, when we did our training at Doctors Hospital in Columbus, Ohio, luckily, we got exposed to a ton of trauma. And at that time, I kind of fell in love with Ferenc Kuhn, who is an internationally recognized vitreoretinal surgeon. I think he's retired now, but used to practice in Europe and was on faculty at the University of Birmingham, Alabama. And he actually helped develop the ocular trauma score and the USI injury registry. And so if you haven't seen this book or you're early in training, it's something great to pick up. It's just got so many pearls in there. And for all the young folks in here, everyone knows what the #1 cause of trauma is. It's minding my own business. So typically, I just want to briefly just touch on some of our terminology. I think it's so key when we communicate with other physicians when we're dealing with ocular trauma to be all on the same page of what we're actually looking at, as well as the fact for benchmarking here. Right now in 2026, about 70% of U.S. ophthalmologists are on the IRIS registry. So making sure your documentation is correct, as well as your ICD-10 codes, help us gather more data on ocular injuries in the goal that we can, try to improve outcomes in the future. So obviously, you're on call and you see someone with trauma, right? The first thing you want to know, right, is this an open globe or a closed globe? And by definition, a closed globe has no full thickness defect. You might have what's called a lamellar laceration or a partial thickness defect. And then in that case, you're talking more about a contusion, which is usually caused by a blunt object, versus an open globe or a ruptured globe, which is usually caused by blunt trauma that basically opens the eye at its weakest point, which might be a prior cataract incision site, muscle insertions, or even contracoup to where the injury happened from that trauma. And usually sharp objects, right, then cause open globes, either in the nature of penetrating or perforation. And the only reason I want to belabor this is that a penetrating injury is typically like a stab incision in and out through the same wound, versus a perforation where it has a separate entry and an exit site. And then obviously an intraocular foreign body is something that's been left inside of the eye. I'm not going to belabor it anymore, but I think it's just really good that everyone has the same level and page for terminology overall. And like I was saying before, this United States Eye Injury Registry is no longer available. It's defunct, but it is a conglomeration of over 11,000 serious ocular traumas. And the whole aim was to study and classify trauma with the goal of improving treatment and prevention in ocular trauma. Like I said before, the largest database we have right now is the IRIS Registry, which is why it's so important for documentation for people researching here. But we know that ocular trauma overall is a disease of the young, typically younger males, 4-to-1 ratio from male to female. And among patients who are older, it's typically from falls, and these people typically present with ruptures of the globe. We know that socioeconomic status definitely plays a role. Lower socioeconomic status leads to a higher risk of trauma. And then when we look at blacks and Hispanics, almost a twofold risk of suffering eye trauma. And black individuals themselves have such a higher risk of having severe and permanent vision loss. And when we look historically, most of this trauma before the 80s and 90s happened at workplace, but with regulations, OSHA, all of these things, it's really transitioned to more of home injuries, do-it-yourself projects. And then overall, about 20% of all of these cases are from assaults in general. And then finally, before we get to some more fun here, when we actually look at intraocular foreign bodies, very rare, about 2 to 3 cases per 100,000 patient years. These patients are usually really, really poor on presentation, commonly may have detachments, cataracts, hemorrhage, and endophthalmitis, portending a poor visual prognosis. And like any trauma, typically the presenting visual acuity will guide you to what their best vision is after any intervention. And I'm not going to belabor. I know tomorrow someone's giving a lecture on ocular trauma. So basically, do your best. You might be on call at the hospital. These patients may be conscious or unconscious, but just do your absolute best to get whatever examination you can. Try to really focus on the main issues causing trauma so you can plan and time your surgery. We're not going to belabor any of this. Just do your best. And I think if you're taking call or if you're seeing trauma patients, it's not anything that's mandatory, but I always document an ocular trauma score. And this is something medico-legally that may protect you, as well as helping prognosticate for the patient. And basically the ocular trauma score is a 2-step process, where in the first step you have 6 factors to come up with a summation of a total score, with the biggest factor being the patient's baseline vision. And then you deduct points for a globe, endophthalmitis, perforating injury, detachment, or an APD. And then you can convert this score to an ocular trauma score to basically prognosticate to the patient, like, hey, bud, yeah, there's a very low chance you're ever going to see again in this eye. And I think it really helps for setting the stage and patient expectations. So I do like to document this in every trauma case that I see. And then just going to intervention again, obviously if you have an open globe, that's something that's immediately going to the OR. Any signs of endophthalmitis, detachment, or foreign body, going to the OR. Everything else, relax. You can probably just treat it casually. The only exceptions are you have someone coming in with significant trauma and they have 360 degrees of like hemorrhagic chemosis. You can't rule out an occult rupture, especially if there's blood in the back of the eye. So do have to take it on a case-by-case basis. And then finally, the worst thing you can ever do in ocular trauma is make a bad problem worse. And so based on your pre-op evaluation, even though it may be limited depending on the situation, I always have to have a solid game plan, have to be able to anticipate what's going to happen, and have to ask yourself, well, are you ready to sacrifice a lens, deal with tissue prolapse, are you going to manage, the retina? And so really, if there's any cases that you have where you don't feel comfortable or the facility that you're operating at doesn't have that equipment, there is never any shame in referring on to tertiary centers or academic centers. That's what they're there for. They've got fellows, they've got residents, and this is where they can get the bread and butter of these cases. So, if you can't, don't, and no one's ever going to harm you. So we're going to start off with a case here and maybe do some patient participation. And this was a guy I recently saw, boy from Kentucky, got a call from the on-call ophthalmologist. He had rigged up his lawnmower, bungee cords everywhere. They broke off, hit him right in the face, so he had bilateral periorbital trauma and some lid lacs. The doc basically fixed up those lid lacs and sent him to me because of his really poor vision and his exam not being able to see the retina very well. So at baseline, this guy was about 2100 in the right eye, count fingers at face in the left eye. Pressure's a little bit high in the right compared to the left, and did have an APD in his left eye. And on slit lamp exam, there was no huge red flags, no signs of any open globe. The right eye did have a little bit of a dialysis of his iris, and his left eye just a minor subconj heme. But we look at what we're seeing here, and I don't know if those pictures are showing up, and maybe Miles, if you could dim the lights a little bit here so people can see a little bit better, but I'll go over this with you. When we look at that right eye, it's an optos photo where the media is a little bit hazy, his nerve is sharp, but you can see some whitening in that macula and more prominently inferior, signs of some commotio, as well as some pre-retinal hemorrhaging there. And on depression, there wasn't any breaks or holes or tears. The left eye, that media is a little bit clear, but what I want to draw your attention to is this macular whitening in a traumatic full thickness hole, as well as this pre-retinal hemorrhaging inferior and actually a subretinal hemorrhage. And luckily on depression, there was no breaks, holes, or tears here whatsoever. And so when we kind of break this down, what do we know? Blunt trauma, no open globe, ocular contusion, traumatic full thickness hole. Based on his ocular trauma score, 90 in the right eye. Left eye was 60. He lost points for an APD, so that left eye is in a little bit rougher shape. And when we look at the OCT even of that right eye on the top left, if you look at the outer plexiform and outer nuclear layer, you see a little bit of shagginess there, which is probably some mild commotio. And then the striking appearance in that left eye of this traumatic full thickness hole. So you're seeing this guy. Who would do anything to that right eye? Hypes, would you do anything to that right eye? You wouldn't touch it? What about that left eye? Wouldn't touch. That's probably the right answer. I don't know if there's anybody else in retina in here can chime in as well. But yeah, typically there's nothing acute here. I wouldn't jump in for surgery on that eye, and we'll show you kind of why here. So I just decided to follow this individual, and we can kind of see his progression on these fundus photos here. And as we kind of look week by week, we see this vitreous hemorrhage clearing, pre-retinal hemorrhage clearing. But if you pay attention more prominently to that left eye, because of that commotio, this guy develops, very significant chorioretinal atrophy. And even at week 1, if you look at that OCT on the top right there, he's had spontaneous closure of this full thickness hole, and unfortunately just has outer retinal atrophy, which is a poor prognosis. But luckily that commotio resolved in his right eye. So this gentleman, a case of trauma, ocular contusion with a traumatic hole, just followed. And at 3 months, his right eye, best corrected, was 20/30. His left eye, 2100, based on his eccentric vision. And so we can, kind of followed that prognostication from the ocular trauma score. So let's get into some more surgical fun here. And this is a recent case I did of a 50-year-old African-American male, was minding his own business and got pistol whipped, probably because the twins or the T-Wolves lost. But he had a lid lac, reported 360-degree hemorrhagic chemosis, formed globe. The on-call doc didn't want to take him for any globe exploration and just sent him into me. Very poor cooperation with a trauma patient, which is pretty typical. Very poor vision, but very poor cooperation as well. And on exam, he did have this 360 degrees of hemorrhagic chemosis as well as a swollen lid. And so I don't have pictures here, but we're going to see the surgical video here in a second. But on dilated exam, had a decently dense vitreous hemorrhage, a detachment, and a choroidal rupture. So the goal here is to, one, ensure that there's no choroidal rupture, and then explore the globe, repair his detachment. Miles, can you hit play on that bad boy? And so here I've already explored the globe. I've got a 2.0 silk retraction suture that I was using to help explore, and doing our standard 25 gauge pars plane of vitrectomy. This guy is phakic here. So we jump right in. We've got this dense vitreous hemorrhage, and often, you want to take your time. You don't want to get too aggressive and end up eating any retina. So first goal here is to remove all of this heme, and we see that detachment, and at the posterior base of that detachment as well, we see some subretinal hemorrhaging. And right now we're going over that choroidal rupture site. We've got blood in all layers there, and there's a bunch of vitreous that's adherent. And so here we really have to get all of that vitreous gel off the break, off the retina and in the periphery, because that's going to be a huge nidus for PVR if we don't, especially in this mechanism and case. And so in these cases, it's always super important to do a 360-degree shaved depression, as well as exploring for any other breaks and making sure we've got all gel out of that eye. So here in a second, we always use different tools to stain the gel, and I'm going to insert some dilute Kenalog or triamcinolone. And what this will do is highlight any additional vitreous, and we'll see it hanging out here, number one, over the site of that retinal detachment and clearing that all up, and as well as a lot of additional vitreous gel in this presumed site of a choroidal rupture here. So just have to be very meticulous in these cases. And so after removing all of that gel, we're going to mark all of our primary breaks with diathermy. And the reason we do that is once we go under air, it makes it much more difficult to actually see the site of that, retinal tear, detachment, or holes. And so in this case, pearl or pitfall, depending on how you look at it, I'm never afraid to use cryotherapy in these cases. And so after I put a little laser to a small little defect I found, I ended up doing cryotherapy around the site of this choroidal rupture. And the reason being, with your laser, you're not going to get good barrier uptake through all of that blood, but you're doing that at the risk of liberating more RPE cells or more inflammation in the eye. But sometimes you have to do what you have to do to make sure this retina stays attached. So here, doing a fluid air exchange, and we're going to drain all that fluid out of the eye, laser this guy up, and then put in probably 24% SF6, slightly expansile concentration of gas. But this guy ended up doing really well. 1 month out, he pinholed to 20/40 because of my surgical intervention. Was really aggressive. Typically when you talk about operating on a phakic patient, we talk about never crossing the midline to cause damage to the lens. However, when I'm dealing with trauma, I'm going to do whatever it takes to get all of that gel out of the eye. So we sent him off to the cataract surgeon. This guy's still doing really, really well. And then for the trauma section here, I got one more fun video for you of a 52-year-old white man referred in for a foreign body, was at work hammering metal, not wearing any glasses. And we have a great ophthalmologist in our town who actually initially saw this guy. He had a metallic foreign body go straight through his cornea, violated his lens capsule, and dunked some of the lens back into the vitreous cavity. But he closed the corneal defects and did a anterior vitrectomy, as well as removed as much lens as he could, and luckily injected Vanc and Ceftaz for prophylaxis against infection. So by the time this gentleman came to me, he was hand motion at face, but again was aphakic and otherwise doing well. Had the corneal sutures, and then on dilated examination saw retained lens fragments, as well as this big IOFB in the eye. So this guy obviously had an open globe, which is now closed here. Ocular trauma score based on his vision is not bad. Loses a lot of points here for his open globe status. And so in this case, we're going to take him in for a vitrectomy, remove the lens fragments, and then you'll see me struggle here to get this foreign body out of the eye, and I'll go over some pitfalls and embarrassments of this case as well. Miles, can you hit play on that? Thank you. And so here again, our standard 3-port vitrectomy. I think one of the differences you'll see in this case, and you can see some of those corneal sutures here in a second, I want to do a vitrectomy in that pupillary plane, not only to remove anterior hyaloid as well, but he had a remnant of his capsule, and you might say, hey, why not save some of that capsule as a place to place a sulcus lens? But in these cases that are high risk of PVR, you got to remove that lens capsule to prevent anterior loop contraction. He doesn't dilate well, so you have to do everything you can to get a great view, so we're putting iris hooks in here to aid in this view. So really in these cases, you have to do whatever it takes to maximize your view and maximize your chances of success. And typically in these trauma cases too, I like to keep PFO on standby. This guy doesn't have a PVD, so instantly we're putting dilute Kenalog in there before we induce a PVD, and we're going to eat up this lens fragment that's in there dancing around, and you can see that foreign body impaled into the retina. At the vitreous base, there's more lens fragments. And then inducing a PVD here, always away from the site of where that trauma is. I don't want to disrupt anything, and I'm going to get his hyaloid up here, clean up all of that vitreous, and then this is where things start turning maybe a little bit south depending on how you look at it. And this is where I probably should have put some PFO into the eye just to protect the macula, because we see that this foreign body now turns into a projectile and starts spinning around. So at this point, our primary goal now is to get that foreign body out of the eye because we don't have a complete PVD in that area. Well, the view is good. I'm lasering around that rupture site of the retina and choroid. So a normal individual or normal retina surgeon probably in this case, and probably what I should have done is removed a trocar, enlarged sclerotomy site, and just used an intraocular foreign body forceps. But I was thinking to myself, well, hell, I've already got these iris hooks in. Let's just put viscoelastic in here and try to shelf this thing and just take it out of a corneal wound and then try to prevent any other traction on that retina. So I'm just kind of forming these pockets and filling up the AC, thinking I'm going to be slick here. And I'm floating this foreign body with a soft tip cannula up into the pupillary plane and then cleaning off any residual gunk that might potentially be on this foreign body. And I think this sucker measured about 3 millimeters in maximal length here. Things are going really well, and I end up just shelving this nasally here and thinking, oh man, you're going to be slick and get out of this case really quick, but nope, that puppy's too irregular and jagged. So I ended up having to break out the foreign body forceps, and anybody in cornea here is probably looking and being like, oh my God, how much corneal endothelial damage are you doing here? A little is the correct answer. But the answer is sometimes you got to do what you got to do, and you learn. So probably in hindsight, probably would have enlarged the sclerotomy to take that out. But this guy ended up actually doing very, very well. We got that foreign body out of his eye, sutured everything up, got in the back of that eye, and I put in a little bit more laser. But it's always fun to see these cases, especially when someone like this who has such a poor visual prognosis, ends up, doing pretty well. So this guy came back post-op, everything remained attached. He never developed any PVR, just a mild ERM, and I follow this guy about once a year. I just saw him recently. One of my colleagues ended up fixating the lens for him. The guy's doing 20/30, so based on his ocular trauma, this guy just did so well. So I hope that was a fun one for you. And we've got some more fun coming up here too, trust me. So I don't know how often you guys see submacular hemorrhage in your clinic. I was talking to Dr. Hypes even yesterday, and these things come in waves of patients coming in, and kind of want to talk about our surgical management that we do at our center, and there's no real standardization, but overall submacular hemorrhage is pretty infrequent in the context of choroidal neovascular membranes, be it wet AMD, polypoidal choroidal vasculopathy, or even just idiopathic CNVM. And overall, among patients being treated for wet AMD, the incidence is under, less than 0.5% of patients who will develop these. But the hard part is once you develop a large enough submacular hemorrhage, that blood is actually toxic to the photoreceptors and can cause permanent damage pretty quickly. And at observation alone, at 2 years, about 11% of eyes with submacular heme had a vision of better than 2200. When we look at these cases untreated, the mean loss of vision is about 3.5 lines, and about 44% of patients, lose greater than 6 lines of vision in cases of AMD. So the diagnosis alone is usually on exam. With OCT, it makes things much easier to delineate sub-RPE heme versus subretinal heme, as you can see in the cartoon on the bottom. But typically when you look in these eyes, if you see really bright red blood, that's typically a sign that that blood is subretinal. very, very dark blood is an indication that that is sub-RPE. And the reason that makes a difference is if you see that bright red blood in the macula, that's something that may be amenable to some surgical procedures. This is actually a patient of one of my buddies from grad school. His mom in India had polypoidal choroidal vasculopathy and developed this massive submacular heme. But just to demonstrate, superior to the macula and fovea, you see that brighter red blood representing subretinal heme in these darker areas where it's sub-RPE, and this is kind of confirmed on that OCT, where you see this large PED and then this subretinal hyperreflective material representing the blood. And just two other examples here for your own edification, and we'll actually see these in surgical videos. The one on the top left just showing a larger component of sub-RPE heme, however, there was actually a large amount of subretinal blood there. And then on the right, a smaller submacular hemorrhage, about a disc diameter in size, but a large amount of subretinal hyperreflective material being that blood. So what do we have overall for treatment? I think in 2026, the no-brainer, no matter what with these patients, is treatment with anti-vascular endothelial growth factor. And research has shown that with anti-VEGF monotherapy alone, that half or more patients may gain about 3 lines of vision. Some things that are more common, not in the US, would be pneumatic displacement with anti-VEGF, meaning that in the office, injecting anti-VEGF and then putting in a small concentration of either pure SF6 or C3F8, an expansile concentration, and positioning that about 80% of the time you can displace that blood. And then in Europe, also more commonly adding on to that would be injecting TPA or tissue plasminogen activator, which actually binds fibrin in that thrombus, converts plasminogen to plasmin, used off-label to break up that clot. And more commonly, like I said, in Europe, they have pretty good success in displacing these hemorrhages without surgery. More commonly here in the US, or what we even do at our surgery centers, if we deem these patients are good candidates for surgery, we'll inject anti-VEGF and then inject TPA subretinally. And there's good evidence as well that we can get great improvement. However, we are very limited overall by large randomized clinical control trials. And about the most recent that we have is a smaller study looking at people with wet AMD and submacular hemorrhage. In this prospective study where patients were either randomized to in-office anti-VEGF, TPA, and pneumatic displacement versus being randomized to a surgical subset with vitrectomy and subretinal TPA injection. But the overall thing to glean from this smaller study is that either the in-office procedure or the surgical procedure, both groups basically had great improvements in vision of about 3 lines. However, surgery does have the higher risk of retinal detachment. So it does make us rethink, hey, should we be changing things up and carrying TPA in the office? But that's a huge burden itself. So we try to avoid that at our surgery center, but maybe changing what we do. So kind of in summary here before we get into some videos is there's no cookbook formula on what you have to do for these patients. I think you have to take it on a case-by-case basis. And typically if I have a patient who has profound vision loss and is maybe monocular because their other eye has pathology, we'll see if they're interested in surgery, but you really got to go over the risks, benefits, and alternatives, as well as discuss the off-label use of TPA. TPA itself isn't benign. At concentrations of greater than about 50 micrograms, you can get retinal toxicity, and I'll show you a presumed case where I probably damaged someone's eye, maybe, I don't know. I'm going to skip through this first one just because we're running short on time here, and we'll get to some surgical videos. And so I have a 79-year-old white female, just 1-day history of acute painless vision loss, and she's count fingers in the right eye, 20/25 in the left eye. And this is the picture we already saw, but it's a little bit enlarged here, about a disc diameter area of hemorrhage, and we see a large amount of this subretinal heme. So I talked to her, based on the amount of this blood, and hemmed and hawed back and forth if we just want to do monotherapy with anti-VEGF or if she wanted to be really aggressive with surgery. And she elected for surgery, so we signed her up for a vitrectomy here, and I'll show you this video here. And Miles, if you can hit play for me. So again, just our standard 3-port vitrectomy here. Again, she's pseudophakic, so clearing up all of that anterior hyaloid and anterior vitreous. I don't want her to have any opacities after the surgery. She's already got a PVD, so our goal in here is to just truncate the vitreous to the vitreous base, 360 degrees. Typically, when you compare to like detachment cases here, I'm not as nuts about doing a depressed shave in every patient unless there's any other pathology present here, but I always like to do a good job, remove as much vitreous as possible, and I always like to depress the retina before I inject TPA, and the reason being is I don't want to displace any of that TPA with pressure that I'm causing on the eye. So testing a 41 gauge subretinal cannula outside of the eye, and here's where I can critique myself and Dr. Hypes too. So sometimes in these cases you have to know what you're capable of doing, and I probably should have cheated a little bit further towards the arcades for my sight for this injection, because I'm going really close to the fovea and the macula. But sometimes in my experience with these cases, when you have a smaller heme like that, if you cheat further to the arcades, one, you're going to use more TPA and risk a chance of toxicity. Number two is you might get these non-communicating blebs of TPA, and then you have to make more of these, small entry sites and cause more iatrogenic damage. But here we see she's forming this nice disciform bleb right around the macula here, not using a ton of TPA because it's a smaller amount of hemorrhage. And so what we do in these cases after we have the TPA in the eye is I like to do about a 50%, 55% fluid air exchange, leaving about half of that eye filled with just BSS, and then put in about 20% SF6 or a non-expansile concentration of gas. And in the post-op period, I have them lay supine, and I say, hey, we're just going to let that TPA marinate there. And after that 30 minutes, they assume like a face-forward position while that gas bubbles in the eye to displace that submacular heme. So we see this lady right here. She's, I think, 5 days out of surgery. We see the big bubble still in her eye, but luckily we've displaced that hemorrhage. And if you take a close look, criticizing myself, you see this little area of retinal whitening superior to the fovea where I entered with my subretinal cannula. So probably want to cheat a little bit further out. But even, there's like a month out here, her vision improved to 20/60 plus 2 from her poor vision, and we see that we've displaced all of that hemorrhage. So overall, pretty decent outcome, but again, maybe cheat a little bit further away from that fovea. And then finally, I'll wrap up here and take any questions, but I wanted to show a case of a possible toxicity here. And this woman was referred from about 3 hours away. We live in a pretty rural area. Had been treated with Vabysmo in her left eye about every 6 weeks. She's basically blind in her right eye from dry AMD, and comes in with count fingers vision. And we saw this picture before, and just refresh you here on this huge component of a PED and then a large amount of subretinal hyperreflective material representing blood here. She elected to get more aggressive because this had been her better seeing eye. So we boarded her for surgery, and very similar to our last case. Miles, if you can help me one more time. Thank you, buddy. Again, I know we're being redundant, but starting off with our standard 25 gauge pars plane of vitrectomy, clearing all of that anterior hyaloid out. And it's going to be very similar. I think some of the differences in this case, she also had a PVD was present, but want to remove as much of that vitreous gel as possible. And I think the only other thing that we're going to see that's different in this case here is that on depression, I did find a very, very small atrophic hole inferiorly. So in these cases, like I said, I always want to treat any of that pathology before we go on to inject that TPA, because we just don't want to avoid displacing anything that's under that retina and lose what tool we have. So we're doing our depression. We can see some residual vitreous gel there, but I'm not usually too concerned about it in non-RD cases here. And this is just going to show from a surgeon's view of that cryotherapy going into the eye, and you'll see this tiny little hole or little dot there right at the ora serrata. There we go. And so maybe a little bit more cryo for good luck here. And then here, very similar case, just injecting that TPA, but I think the differences in pearls and pitfalls, I wanted to show a case where you can critique yourself here a little bit. Again, large hemorrhage, and I think in this case I usually have one of our techs is injecting the TPA, and they're keeping me updated on how much that we're injecting here, and sometimes this fluid under the retina can get away from you pretty quick, and you'll see compared to the last case, I did make a really, really large subretinal bleb here. I've made bigger before, but concentration here was probably a little bit stronger. I think we used about 15 micrograms per 0.1 cc. So we see this huge, huge bleb. So one, pearl and pitfall here, probably used too much TPA in this eye. And then the other pitfall I'm going to show you here, like I was saying in our first case, typically I like to do about a 50-55% fluid air exchange. In this case was maybe a little more aggressive, and you see we have a nearly complete air fill here, probably 80 to 90%. And then the reason that this is a problem in a case like this is I'm going to put in SF6 again, but the surface tension of this big bubble, right, is going to keep that loculated pocket staying there. So despite positioning, we've trapped that TPA in that same position and kind of are not letting gravity be our friend to displace that hemorrhage anymore. So we'll see here, she comes back post-op, I think, day 10 or more, and we've displaced that hemorrhage. She does have some residual subretinal hemorrhage there, but you can see gravitationally it's all down. And I don't know if you can notice, if you look at this perfect appearing dome-shaped, curved linear area where that bleb was, you see all of this, chorioretinal atrophy, and you see that extending inferiorly. So you never know how much of that is from the hemorrhage itself, but in this case, with the amount of TPA and the concentration that I used, I probably did induce somewhat of a toxicity there. And then there's her post-op OCT, much better in appearance. She did all of her follow-up care about 2 hours away, but I still get clinical correspondence from the retina over there, and luckily she's 83 now, but she's maintaining vision of about 2100, so still her better seeing eye, and she's on bevacizumab now. So hopefully overall you guys got to see some cool things that we do in retina, some of the challenging and complicated cases that we get to see. But I'm going to turn it over here to my friend Dr. Hypes, and then I think we've got a panel after this. Does anybody have any questions, concerns, comments? Correct, yeah. We don't use I don't, connect to the machine and depress and inject. I just have the techs do it, and we hook up a line, and then for each 0.1 cc that they inject. I've done it in the past, with a VSC cannula, right, where you're depressing and you can control a little bit more. But I've also had cases there where then you get issues with the plunger, or you get too aggressive in injection. Our techs are pretty good, so do you guys use?
Yeah, I do the VFC device, and I find if you put the injection pressure down on that,
Sure.
it's really hard to put
Too much.
because it's so slow.
And that's a great point. What Dr. Hypes is talking about is by lowering that infusion pressure, you have a much lower gradient between the intraocular pressure and the pressure that you're exerting under the retina. So maybe what he's alluding to is a much more controlled manner in injecting that. Yeah, I keep usually infusion anywhere from 20 to 30, but that's a great point, if you're worried about that TPA getting away from you.
I may have missed it, but on the submacular hemorrhages, is there a time frame in which you get them to you versus there's no work, it's not worth it?
Yeah, that's a great question, and so I alluded to it very briefly, typically as soon as possible, but if you get beyond 10 to 14 days in that time frame, if they're out beyond that, we're having a greater discussion of hey, we may have missed that window. Rarely if they're super, super aggressive and saying, hey, I want to do anything possible, I'll say, I'll take you to surgery, but, we're talking still a Hail Mary anyway, but it's a great question. Come again, I'm so sorry. How are you dosing it? So I would have to look back. I follow when I do it. I haven't done it in about a year, but I followed the protocol straight from the GUARD trial. And then we actually are lucky enough that we have a compounding pharmacy 2 blocks away, and methotrexate is, dirt cheap. And so it makes it easy, but I would have to look up that. We followed it exactly when we do it, the GUARD trial. How about yourself?
I'm doing what Raymond initially presented in 19, do it 1 week, 2 weeks after that, so 1, 3, 6, and 10, give an injection. Initially, I put it in the operating room, but I got a lot of inflammation on a case, and I was like, I have to just swallow.
And personally, what are your thoughts on methotrexate? Have you seen success? Hard to tell. Fantastic.
If I had a detachment, I would want methotrexate. I've seen it work really well. It works well in young patients. It works well in patients with PVR. I think I've had maybe 2 cases redetached from PVR on patients I've used methotrexate. So I'm working on that.
That's great. Yeah, and I do use it still in aggressive cases. I think the thing is, what we're talking about too is one, the off-label use. Two, the other issues are we always have to deal with corneal toxicity. I've never seen corneal toxicity. Have you ever seen corneal toxicity from these cases? No, not at all. I think the hard part too, what Doc was alluding to was too, is it is more of a burden on these patients because they're coming back frequently for these injections, but it really slips pretty seamlessly into your clinic with your shots and injections. And I think that there is some merit. It's probably the best pharmacologic evidence that we have. I think the other thing is Chris Reinman, he's starting a new study right now, but he's talking about actually just right in the BSS bottle at surgery, and he's shown some preliminary data that's pretty good, and I'm thinking about implementing that at our surgery center. I think the concerns about that are right, is, mostly at our surgery center, we have got great techs, but they're all, younger women, childbearing age, and so then the other things you have to consider is, handling, this chemotherapeutic agent and the potential risks there, but that's what I'm more looking forward to, just because PVR can just be the absolute bane of our existence, you know what I mean? Very cool. Yeah.
A few comments on the timing of submacular hemorrhage. I think I purposely wait to the 10 to 14 day mark anyway, because from the vascular literature and ophthalmic literature too, you're actually better off for clot lysis, and having that clot break up by itself, it allows better sort of liquefaction and the TPA to work better. So taking an acute submacular hemorrhage actually wouldn't work really well, and you want to wait purposely for that. Sign them up for surgery, do the anti-VEGF in the office, and then delay the surgery about 7 to 10 days, somewhere in there, because you're going to get better results done. And that's supported in the vascular literature too, doing clot lysis and peripheral vasculature. The second comment I have on that trauma case with the African American male choroidal rupture you had, awesome video. Would you now, looking back on it, would you have prophylactically healed ILM?
Yeah, that's a great question, and that comes up for debate a lot. And typically, I think in the absence of PVR on a primary surgery, I'm going to avoid any macular work, just in the sense of, one, causing potential iatrogenic damage, and two, there is, evidence out there that you could be creating, microscotomas, decreased contrast sensitivity, and these things. So in a primary case, in the absence of PVR, I don't. I think the other thing, looking back on a case like that, trying to be as aggressive as possible, is in those cases saying, hey, would it be worth adding a scleral buckle at that point too, as well, to support the vitreous base in someone who is at higher risk for PVR? So that was the other consideration. Do you typically prophylactically peel ILM?
On a young guy like that, where I'm worried that even there's maybe a layer of hyaloid that maybe stepped down, healing ILM, I always start like inferiorly, so if there's going to be a scotoma, it's going to be more inferiorly.
Sure.
Not noticeable. But nowadays, any MAC off already, I'm healing ILM. I'm getting very good success rates in preventing PVR in general because there's no scalpels anymore.
Sure.
At least in the arcade, around the arcades, widely. And then back to the methotrexate comment, I used to put it in the infusion or intra-op, but there's also been some sort of comments in editorials saying that, well, you may also prevent your laser from creating that adhesion if you put methotrexate in. Now the laser will, you have these little iatrogenic breaks, and you won't create that adhesion for your pexy. So I delay my methotrexate to at least a week post-op. I think it helps me sleep better. I'm not convinced that it
Sure.
does anything. So there's going to be a nice debate at that at Retina Day at AAO. We'll see. One of my colleagues is debating. Yeah, it's going to be interesting. And then, but I just like prophylactic IOM healing, a good retinectomy, and that's how I do it.
Nope, that's great. So one question for you, quick. Do you, in your recurrent detachments, if you've already peeled ILM, like I know Yoshi over at Will's Eye, he's written several papers on peeling as far as you can. Do you try to peel out as far as you can that ILM?
Peel as far as you can, and then you just have to see what the retina feels like, because people don't want to do retinectomy. It's like anti-ethos. Take the retina.
I agree.
Because that foreshortening is a real thing.
For sure. And then the worst thing you want to do is be in the operating room and kid yourself and say, hey, this retina is, even under air attached. knowing that it's just going to pop right back up. But in your case, what I was alluding to is I find it very difficult because you can get a good ILM peel in the macula, but then it gets very difficult as you get to that periphery. And I mean, you can use everything, but if you can in the cases, I think it's great because you do eliminate that scaffold. Great questions and comments. All right. Thank you, everybody.
Thank you very much, Dr. Strand, for that excellent lecture. We really appreciate it. Just by way of announcement, a few things that the college would like to remind our attendees of. Please take time during the day to visit our exhibitors in the exhibitor hall and show your appreciation for them coming out. We do have the Corkigans Cantina right outside the exhibit space, which is an exclusive cash bar, and that will run from 4 p.m. to 10 p.m. tonight. And then also, please attend our lunch product theater with Regeneron at 12:30 in the Highland Room. Let me see. Dr. Hypes had to step out for just a moment, and I don't have my stand-up comedy routine prepared, but I am going to go ahead and introduce Dr. Hypes as well as our other panelists who will be joining Dr. Strand and Dr. Hypes on a retina panel after Dr. Hypes' lecture today. Dr. Stephen Hypes earned his medical degree at the West Virginia School of Osteopathic Medicine. He completed his ophthalmology residency at Beaumont Health, South Shore in Metro Detroit, followed by a vitreoretinal specialist surgery fellowship at the Ochsner Clinic in New Orleans. Dr. Hypes has served as clinical faculty for the University of South Carolina and the Prisma Health Ophthalmology Residency Program since 2019. He established a 2-year AUPO-accredited Retina and Vitreous Surgery Fellowship in 2022 and continues to serve as its program director. Outside of medicine, Dr. Hypes enjoys traveling with his wife and sons. He also enjoys playing guitar and sailing in his old rickety sailboat, Proclivity. The SS Proclivity. And when time and weather permit. Dr. Hypes, please. Thank you.
Great. Thanks, everybody, for being here bright and early for the most exciting topic in ophthalmology, uveitis. I'm kidding, of course. How many people here medical students? And residents? And comprehensive ophthalmologists? Any uveitis specialists here? Seriously? Do you? And rheumatologists? Good, all right. When I was asked to speak on uveitis, I thought, well, yeah, I'll put together some case presentations, some real zebras, medical mysteries, and show you all how smart I am, which really isn't the case because it's always a multidisciplinary team and a lot of lab work and time that solves the mystery. But the other thing, too, is with this audience, I didn't feel like that would be a great way to teach because there's not a lot to take away from that. You saw some exotic stuff, but didn't learn a whole lot because you might never see these cases, you might never have to manage these cases. And so I was thinking practically what would be useful. And so I wanted to revisit how I approach uveitis clinically and say, well, what's been changing in the landscape? How, from when I started managing these conditions to what is the move forward with development of drugs and delivery mechanisms? So that it would be more practical and hopefully you could kind of start thinking about new ways to approach some of these conditions instead of just firing steroids at everybody. So we'll get started. I do have to apologize. I haven't made a PowerPoint in over a decade, and so I would grade it on about a 7th grade level. So it's going to be pretty weak. No relevant disclosures, and I can't see because of this thing. All right, good. So these are our learning objectives here. I want to look at implementing kind of a tiered workup approach instead of shotgun labs. Look at some of the biologic options. drug delivery mechanisms, some surgical decision-making things we have to review. And then one thing that we don't talk about enough is assessing patients' quality of life. In retina, I often feel like the grim reaper sometimes of patients' vision because they come to you usually too late to help in some cases. And having the discussions, especially as DOs, right? We need to see our patient and not the symptom, not the problem, and treat the whole person. And thinking about how living with low vision has a negative impact on patients' quality of life. We'll start with some new diagnostic standards. So last year, the JAMA review of uveitis, the big thing that came from that was not getting shotgun labs. When I first started out, I don't know how many people have a lab order sheet in their office with every lab under the sun. And when I was first starting out, I just went check, 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 check. Because you hope you just send it off and something comes back positive, and you can say, aha, we've got it, and now we know what to do with it. Or you hope something comes back positive and you don't feel guilty sending them to a rheumatologist. But the new approach is really looking at the different phenotypic variants of these different entities, because they are different entities. We say uveitis like it's one thing, and I'm talking about in this presentation, obviously non-infectious uveitis, right? It's a myriad of different diseases with very, in many cases, very unique phenotypic presentations, and so that should tailor your lab ordering. So this was kind of a summary of some of those, like the quick and dirty version of it, but you could get more into the weeds. But looking at bilateral versus unilateral, granulomatous versus non-granulomatous, age, race, all play a factor. I mean, if you, an ANA has very low positive predictive value in your average uveitis patient. If you've got a possible JIA kid, sure, but shotgun labs don't have much utility. So I don't need to read all this to you, but keeping your thinking cap on. The biggest things is making sure it is non-infectious uveitis, because if you treat infectious uveitis with steroids, you're going to make it worse. The other updated guidelines came from the UGIG, the Uveitic Glaucoma International Group, and just something to be thinking about for the medical students and residents. You go, oh, you've got a pressure of 17, that's normal, that's great. In a uveitic patient, that's not normal or great, and so you have to watch these patients a lot closer. They found patients between 16 and 21 you should see every 3 months. If the pressure's not responding or not lower than 16 on 2 drugs, send them to get a glaucoma referral. Uveitis patients are at high risk for pressure for a number of reasons. One is just the primary inflammatory disease. Second is the steroids you're using to treat it. And so getting glaucoma specialists involved early is warranted. The other thing they mentioned in this update was using, sorry, I chuckled as a retina specialist, using a Goldman applanation tonometry and checking your pressure yourself. We get in a groove in our clinic. I see 65 patients a day, and we trust the Tonopin and whichever tech is there that day to check the pressure. And if it looks like it makes sense from visit to visit, you just kind of go with it. But in your uveitis patients, take the time to put the fluorescein in, check it yourself with Goldman, especially because a lot of these patients will have corneal scarring or band keratopathy and things, and it can make your Tonopin readings very unreliable. And so for these patients, taking the moment to know that the pressure that was in the last visit compared to today was one you checked yourself with applanation tonometry, so it is reproducible. And the other thing, too, to think about is all so many patients have concomitant diseases, right? And a lot of them already have open-angle glaucoma, but in uveitic glaucoma, don't approach it the same as open-angle glaucoma. The first-line agent isn't latanoprost, right? I mean, I don't know if that's still anybody's first-line agent, but it was when I was managing open-angle glaucoma. But in these patients, it's got a pro-inflammatory component to it, and it makes cystoid macular edema worse. And so I typically start with Cosopter brimonidine with these guys, just so you can take that off the table. Because if you're sitting there watching CME not resolve and they're still on a prostaglandin, you won't know if that's the reason why until you stop it, so don't start it in the first place. That's kind of my opinion. The next thing I want to talk about that's happened in the last 365 days that people are discussing, adalimumab or Humira has taken off in the systemic management of uveitis by rheumatologists. What we want to think about is getting these patients off steroids as quick as possible, right? When I was first starting out, it was, I just tell my patients, like, if I walked in the room and the trash can was on fire, I'd put the trash can out, and then I'd figure out who started it, right? So we would go in and say steroids and just hit them hard and get it quiet, and then taper off their PO steroids or figure out the longest acting intraocular steroid to use to keep the fire out. And if the fire was staying out, then that's good. We've solved the problem. It's a chronic condition, so you need chronic steroids, except that's not good. There's a lot of sequelae that come from chronic steroid use, cataracts, intraocular pressure spikes. And for a long time, when we had to get the rheumatologist involved, they'd start with methotrexate, and then you'd still be co-managing it, and the disease would quiet maybe a little bit, but they'd have to be on it forever. And so a lot of people have shifted over to using adalimumab as a first-line agent. They're finding that people are getting off steroids much faster that way, and it seems to have more efficacy even by going to a weekly dosing from bi-weekly dosing. The other thing, how many retina specialists in the room? All right. Biosimilars is something in our intravitreal injection space has been a huge conversation for the last few years. And so when I was looking into it on the rheumatologic side, now that there is an adalimumab biosimilar, insurances are going to tell us what we have to do in that regard. I have a lot of patients that I want to escalate their intravitreal anti-VEGF to something that I think is safe, effective, and works great. And the insurance company will say, we have to go through step therapy and try this first. And so fortunately, in the retina space, with intravitreal injections, the biosimilars on paper, in the data, and clinically, I've found to be pretty equivalent to their originator. I don't have really any issue having people on biosimilars. I use a lot of different ones, and they all seem to work fine, which is good. And so I was happy to see that the data for adalimumab biosimilars also says the same thing. So what you might, I was trying to think how that applies to a general ophthalmologist, and what they're going to say is, you've seen this patient who's on Humira and quiet and happy. And then they want to switch me to adalimumab something, and he goes at this, and it's the biosimilar, and you can let them know that it is okay, that these are safe and effective, because patients are skeptical when it comes to something like that, especially if they have to get switched off of something because they've changed their insurance. It's after the beginning of the year, and now they've got a flop. But letting them know that the data is compelling, that compared to the originator, they're equally effective. And then looking ahead, I found this interesting, this TRS01, I can't pronounce that intelligently. It's a macrophage modulator. It's basically a drop that works as well as a steroid, but doesn't have our steroid side effects. That's in clinical trials right now, I think phase 3. And then there's Stelara. They're looking at that for Behçet's and Crohn's right now too. So there are, I think, in the pipeline for drugs, if it's anything like what we're seeing in some of our other retina disorders, is just these patients, I think there's more hope for them to have a solution just based on how much more durable and effective things are becoming. And so that's one thing, as we talk later about their quality of life and depression scores and things like that, is that what these are now is good. It's better than what we've had, and something better is coming, right? That's kind of how I frame that discussion. Other update in the last, this is greater than a year old, but a conversation that's happening a lot more, especially with my partners, is delivery mechanisms for intraocular steroids. So we all start them on drops when they get there. That gives us 2 weeks to get some preliminary labs and hope that it works, and then they come back in 2 weeks. Our TB and our syphilis labs are negative, so we can go periocular or intraocular now if it's not working, right? The suprachoroidal delivery system, Xipere, it's suprachoroidal triamcinolone. I have been the biggest fan of intravitreal dexamethasone implants. Ozurdex. I have used them a ton. I think they work great. And the patients who don't get a pressure response, they're quick and easy. If you're selective about your patient, anterior chamber migration is extremely rare with Ozurdex. But it does have drawbacks. I feel like it's at least 10% of them after their second or third one come in with a high pressure. And it is important when you're looking at a uveitis patient you're managing with steroids to gonio them when their pressure is high, because sometimes it's not the steroid, it's subclinical, subclinical NVA. So taking a moment to look at that and make sure that there's nothing in the angle and that it truly is the steroid response. But the suprachoroidal delivery mechanism has some benefits, and it's that you're not getting this bath of steroid over the lens and into the trabecular meshwork. It stays in the posterior segment, which is especially helpful when you've got posterior uveitis. Which is good. There are some drawbacks to it if you're considering using it. As technically different than the injections, the STKs that we're all used to doing, or the intravitreal Ozurdex. So there is a little bit of a learning curve, and if you're not doing it often, like anything we do, you're not going to be comfortable doing it infrequently. The other thing too is that suprachoroidal injections hurt. And that was the weirdest thing when I was training on this thing, was that they were like, it was like the old Head and Shoulders commercials, like that's how you know it's working. And like the patient's gonna go, ow, ow, that really hurts. And go, oh yeah, that's how you know you're in the right spot. That's horrible. You know, I do subconj lidocaine on at least half of my anti-VEGF patients just because I feel horrible stabbing them in the eyeball. I don't want them to feel any pain. And so that is one big factor there, is that it doesn't feel very good. So who, in my opinion, is a suprachoroidal great for? It would be someone who'd otherwise be on Ozurdex that's functionally or actually unicameral, because you can't put a steroid implant in a patient who's functionally or actually unicameral, because that thing will migrate. They can never look face down, at least for the next 12 weeks. And so if you've got a patient who's got a sew-in lens or is ACIOL, that's another good way to, instead of doing periocular, you want something a little more posterior. So that's who that is getting those in my clinic, is all my people who have had dislocated IOLs because their uveitis destroyed their zonules and the bag broke in surgery. So my acreose people, those are the ones who wind up getting that. Here's a little picture here. You can see where the injector goes and how it directs the medicine posteriorly and keeps it off of your lens. I woke up this morning and realized I had no images in my slideshow. And I said, oh, I better throw something in there because it's not too boring. How many cataract surgeons in this room? Good, great. Thank you all for what you do. Thank you for your service. I'm very grateful because I don't enjoy cataract surgery. I've done 2 phacos in the last 9 years, and I broke the bag twice and said, thank God it's in the back. I can go work on it now. Traditionally, the adage was you want 3 months of complete quiet before you get in there. You want to know the disease is well controlled, that you're safe to go in, that decreases your risk of reactivation, right? And that adage still is fairly true. And last year, the update for this presentation's purposes was that the ASRS, American Society of Retina Specialists, confirmed that a hydrophobic acrylic lens like an Acrosoft is the preferred IOL to put in these patients. The inflammatory debris doesn't attach to the surface as well. They tend to get fewer membranes that come across, because the membranes you get in these uveitic patients aren't yaggable, and a lot of them wind up, if they don't have an acrylic hydrophobic lens, need an IOL exchange, which is a pain in the petunias. So the other thing for your cataracts I just threw in here, obviously you guys probably know this in your uveitic patients, is that there's a higher risk of complication, not just from the fact that they've got fragile bags and they've got posterior synechia that you have to lyse, the zonules are terrible. You risk reactivation even if they have been quiet beyond 3 months, and so I'll often tell my cataract colleagues, throw a little subconj triamcinolone in there, do an STK, or I'll do one before they go just as a prophylactic to be on the safe side. But also before you do that, like I said earlier, gonio your patients, because you don't want to find out they had subclinical NVA when you put your paracentesis blade in at the start of the case and they start bleeding. Because they can actually have that and not necessarily have a high pressure yet. And I wanted to find another good reason that you can't wait 3 months, and it's this guy. So he's had uveitis, and he's got posterior synechia, and he's got neovascularization because he's been managed poorly. This wasn't my patient. But he's got ectropy and UVA so bad it's ripping his anterior capsule open. That's one that I will spare you all, and I'll take it myself, and I'll do a lensectomy and eat the bag after I've done some anti-VEGF, and then possibly do a combined or send him for a tube with one of my partners or one of my colleagues in the community. But these are ones where you can't even see in. We need to know what's going on back there. My B scan is suspicious. There's some elevations. I don't know what's going on. I can't see. And so waiting the 3 months isn't going to work. We want to quiet them down acutely with steroids, anti-VEGF, and get that lens out of the way so we can see what the heck's going on back there. Recently, the only for peds is kind of the systemic stuff, right? And so just like adults, I think they're finding that moving towards faster steroid-sparing treatment is warranted, and so they don't wait for methotrexate to fail anymore, and so they're using things like adalimumab to try to get these kids off steroids. Band keratopathy and posterior synechia in pediatric rheumatologic uveitic patients used to be a foregone conclusion it was going to happen. It's not really inevitable anymore, and having a kid get band K and a cataract, in their teen years has a big impact on the quality of life for the rest of their life. And so just like with pressure, just like with aggressive disease, escalate, right? You don't have to manage this stuff alone. And I think when I was first getting into retina, I felt like if I could manage the ocular stuff and there was no systemic involvement, then I was just going to keep doing Ozurdex every 12 weeks because they see good, the eyes are quiet. Getting your colleagues involved, even for a double check, especially for kids, and not just the specialist, not just a rheumatologist, the pediatrician needs to be in the know too. This is the communicating. None of us have time to call their pediatrician, but make the time. So you're always talking to parents about who's this doctor. At the end of my day, throughout the day, I keep a piece of paper in my pocket, write down every patient name and doctor that I have to call at the end of the day, because if I don't do it at the end of the day, it will never happen. And I always give them my cell phone number because they never call back when I'm sitting at the desk either. They're going to call you when you're driving to your other office. And so escalating, especially in kids, especially if they've got systemic symptoms. So if you've got a kid with iritis, and the kids don't tell you what's wrong with them. You can't be like, do you have any joint pain? Like, no, I don't know if does anybody ever get a good history from a kid? So I'm relying on pediatricians, rheumatologists to help me fill out the picture instead of feeling like I have to manage everything by myself. So the last real thing that I wanted to discuss is the topic of conversation about quality of life, and this is something that people are bringing up a lot more frequently. The NEI has the Visual Function Questionnaire 25. It's a truncated version. Do any of you guys ever use that? No? Yeah, me either. No, but it is something that even if it's an awkward conversation to have a low vision patient struggling with chronic disease to say, I'm going to have you who can't see fill this out. You can't see it, I'll read it to you. That's weird, but you can use the questions on this if you're not going to do it to, one, think about the different ways that quality of life can be affected here. How their visual function applies to literally every facet. We think about it all the time as ophthalmologists anyways, but also how to ask those questions in a way that the patient can give you what they're willing to. But I do have a rheumatologist colleague who actually happens to be my neighbor, thank God, because I know where to find him. He does use this on the patients that I send him because they have they've got a therapist in their practice too that helps provide the type of counseling for people who are struggling with chronic disease. It's not something as a retina doctor I've ever thought we need a therapist. We should probably get a therapist. But we ignore this part a lot. And so just wanted to make sure that I stuck a slide in here to remind you guys that anxiety and depression, especially in uveitis patients, so we deal with it because we've got people coming bilateral tractional detachments too. It's still applicable. But there's strong data that says patients who are living with uveitis really do struggle. And even sometimes when the disease is under good control, even sometimes when the vision's good, even sometimes when the joints don't hurt, that lingering, I'm not well. My body is trying to self-destruct, and it's making my life difficult. So keep all that stuff in mind when you're managing these folks. So conclusion, tiered workup, focused, no shotgun labs. Pounding with steroids for a long time is not a good long-term solution. You got to put the fire out, but that's not a great way to keep it out. Remember, check pressures yourself on these patients, just because there is enough data that says relying on tonopens alone can lead to false sense of security. Be comfortable with new delivery mechanisms. The suprachoroidal delivery mechanism is good for posterior uveitis, but it's not applicable to everybody, but there are a few people that it is the absolute perfect thing to manage the disease with. Biosimilars are fine at the moment. I haven't seen anything to the contrary, so don't be afraid of those. And then escalate. Don't feel like you have to manage this stuff yourself. I think moving towards a multidisciplinary approach is becoming much more standard, and there's no shame in my game. I will call anybody to just be like, okay, that's what I think I got, but I want you to see them and you to see them, and primary care, I want you to know about this, because the more people you have involved, uveitis patients, famously non-compliant. I don't know if you guys have ever seen that in your practice, but my least reliable patients are sometimes my uveitis patients. They'll disappear on me for 2 years and call when they're having a flare-up and demand to be seen that day. And so if you've got their primary care physician and their rheumatologist and everybody else in the mix, maybe they've seen one of them since they saw you last, and that can also help prevent the damage that can come from this wretched condition. All right, let's see. So these are basically the trials and clinical guideline stuff. I pulled all this information from, as I was saying, what's new in the last 365 days. If you want to take a look into it deeper, there's a good breakdown too of the phenotypic variants that you can kind of put in your head when you're looking at these, so you're not, doing these shotgun lab workups on people. So, all right, you get a quiz. Andy? Yeah. This is for you. I just want to make sure Andy was paying attention. All right. What's the recommended approach for initial uveitis workups? Someone yell it out. Do what? Oh, you can't read it, too small? All right. The JAMA Clinical Review Diagnostic Standardization, what's the correct initial approach? Universal shotgun testing for all autoimmune markers, tiered phenotypic-driven approach based on anatomic location, anterior, posterior, mandatory genetic testing for all patients under 50, or deferring all testing until the second recurrence of inflammation. You're going to go with B? Are you sure? It's B. The reason I have D in there is because I had an attending once who their approach to iridocyclitis, just straightforward, show up one day, unilateral, 1+ cell, photophobia, start them on some drops. They'd say, we're not going to do anything until the second time this flares up. We're not going to send you down the rabbit hole. And I did that for a really long time. And I don't think you need to change that in very straightforward iridocyclitis, especially if someone had a cold 2 weeks ago or there's some other explanation like, my kid might have bopped me in the eye, I don't know. But these are patients that it's going to hang there because as a retina guy, there's always a second recurrence, or that's usually when they're coming to me. But yeah, the answer is B, have a tiered approach. How does suprachoroidal delivery of triamcinolone differ compared to traditional intravitreal steroid implants? It is less effective at resolving macular edema, carries a higher risk of endophthalmitis, provides similar efficacy for CME with a lower incidence of steroid-induced IOP spikes and cataracts, or is only indicated for anterior segment inflammation. Anybody? Yes, good, you listen. All right. Clinical evidence concluded regarding the use of adalimumab biosimilars in treating non-infectious uveitis. Biosimilars 20% higher rate of treatment failure, non-inferior to the originator, should only be used in pediatric cases. Switching to a biosimilar is contraindicated in patients with active macular edema. Great. According to the 2025 ASRS updates on the surgical management, what IOL material is preferred for secondary IOL implantation in the uveitic eye to minimize postoperative complications? Very good. And I put the Sensor 3 in there, having a hydrophobic acrylic 3-piece as backup too, because the bags do break more often in these patients. So if you do need a sulcus lens, make sure the material's the same. I'm not referring to like piggybacking, obviously. All right, last, JIA patients. How does this step forward treatment strategy differ from traditional models? Avoid systemic therapy until vision's 2200. We have a lot of medical students here, okay? Can't make it too hard. Using topical steroids as the sole long-term maintenance therapy, moving to biologic therapy earlier in the disease to prevent structural damage, or prioritizing surgical intervention over medical management. Very good. All right. Thank you all very much. I appreciate it. I really can't. Uveitis has volumes of books written about it, so to cover uveitis as if it's one entity is kind of worthless for the kind of group and setting that we're in. So I was really trying to think practical, how can you start to approach these things? Getting off steroids early, not getting worthless labs with low positive predictive value, embracing new things, and phoning friends, knowing when to escalate, and getting a multidisciplinary team. So those are the big changes, and those are changes that I've made even since I started doing this, 8 or 9 years ago. So I knew this wasn't going to take 50 minutes, and I tried to talk slow, but when I'm presenting, I tend to, But I did want to leave plenty of time for questions, because that's where I feel like I could offer more. If you guys have, how would you approach this, or any of the successes or things you've learned from applying things in the last few years that were different than how you did it when you first started managing uveitis. So I do my own preliminary labs, and usually the preliminary labs are just ruling out, first of all, in Columbia, South Carolina, we have a huge sarcoid population, and so I do see a lot of granulomatous uveitis in a middle-aged African-American patient, and so sarcoid is a great masquerader too, and so you always want to rule that out. And then I got to get syphilis and TB. Lyme is not really endemic, and so if it's a white guy who goes on hunting trips all the time, yeah, I might get a Lyme, but if it's a little old African-American lady who lives in her apartment all day, I'm not going to get a Lyme on that. But the main reason I do those preliminary labs, especially if there's no systemic stuff. If there's systemic stuff, you're going to tailor what you're doing to try to hammer down a diagnosis. I can't put steroids in an eye if I haven't ruled out syphilis and tuberculosis, because there have been several cases where people put Ozurdex in an eye without ruling that out, and they made the thing blow up. So if all that's negative and I can manage the uveitis and there's no other systemic stuff, I really don't go digging. But if there's any suspicion that there's systemic involvement, then I'll let the rheumatologist do the deep dive. I'll occasionally get a chest x-ray too. But very focused, very minimal, and just to tailor how I can put that fire out quickly. And then when we're trying to, like if there's someone who is steroid dependent to manage this disease, then we have to escalate. Because I used to be fine just saying, all right, you've got this in one eye. We never figured out what it was, but here's an Ozurdex every 12 weeks for a year, and now we can put a fluocinolone implant in there. One thing about fluocinolone implant, anybody in here ever inject Utique or Illuvian? Good, they work, they're great. That husk never dissolves, ever, ever. So I had a fella that I injected an Illuvian in 5 years ago, and it didn't seem to be as effective as his Ozurdex, so we went back to Ozurdex. And about 6 months ago, he came in, and the cornea was real cloudy, and I saw a little opacity down there, and I was like, Ozurdex migration. This is my first Ozurdex migration. I try to be really selective about these patients. It was his Utique from 5 years ago had migrated up to the front of the eye. And I've had some other folks that, have had several now, because you can inject it once a year. It looks like a little Utique graveyard down there. But those husks never go anywhere. But yeah, so I lost track of what we were talking about. Yeah. Oh yeah, so that's anyways. Yes. I am not aggressive with breaking those in phakic patients at all. And if the disease is quiet and they're not sneak down 360, their pressure generally stays pretty good. We're seeing them often enough and checking their pressure. I don't primarily use atropine to even assume I'm going to break the synechia, because usually by the time they're getting to me, it's been going on long enough. If it's an acute thing, we're trying to prevent synechia, right? And that's why I do it. So prevent the synechia until the eye's quiet, but also for comfort, because these patients have the Irish Charlie horse is what I call it. So if you can cycloplegia them, it's for more pain than anything. I let my wonderful cataract colleagues manage synechialysis in these patients, unless I have to go do a lensectomy, in which case I will. And that's another point too. Andy was talking about the scaffold for PVR when you're doing a lensectomy on these folks. And if I'm doing a lensectomy on a uveitic patient, I'll often just take the whole lens, the zonules, the bag, and everything, because that's scaffold for the inflammation. If there's capsule left behind and you had a PI and sew in a lens, put in a PI, it'll plug your PI, and then you got to send them for another YAG. So it's a pain. But yeah, I don't do anything until I do everything. So.
Atropine's not a great choice for uveitis either, because the drop will dilate for 3 to 7 days. So you wind up forming scar tissue in a dilated state, 360 degrees, right? So cyclogel is a much better choice because it will only last like 12 hours. So if you do it twice a day, your iris is constantly moving, preventing the synechia formation, and also you're helping with the pain control there too. If you're getting synechia that form within 7 days, you can inject TPA within the AC, and it will bust up and break up the early form synechia if they're acute and new. If they're older than 7 days, they won't break up. You can also do that TPA for heavy fibrin. So like in your HLA-B27 patients, you get like those huge fibrin plaques. If it's within 7 days, you can inject TPA and it will instantly break it up within 30 minutes, and the vision will improve.
That's good intel. I usually, by the time they've made it to me, they've already been on cycloplegic, so that's super helpful. Do you find, I have my true HLA-B27 associated anterior uveitic people, like a extremely rapid improvement in the inflammation on steroids, like freaky fast.
Yeah, HLA-B27 is really sensitive to steroids, or if you hit them hard enough.
Yeah.
And so HLA will typically do that, where you have these rapid explosions and then rapid calm down. So the question is really like, is it self-resolving because we're hitting them hard enough with steroids, or is it actually just like the nature of the disease because they're so explosive? Right? But they are responsive to steroids really well there.
Yeah.
Those are great ones for like, depending on the degrees of inflammation and how explosive, are you considering like PrEP Q1 hours versus all QID versus oral steroid, just to knock it down.
Yeah, it's really neat when you see it, and your residents and fellows are going to think you're a wizard when you see them back and it's like completely resolved. And you're like, that lab work's going to come back HLA-B27. Like, how does he know? Any other questions, comments? Is if it's purely ocular and it's unilateral, those are the folks that are still, I escalate. I usually get them through the Ozurdex, make sure they're compliant people, and then I like that fluocinolone implant because it lasts so long. I still see them every 3 months, but I want to inject them as little as possible. I want them to need me as little as possible and call me as little as possible. But also, I don't personally, especially in an older patient, put them on something that's going to modify their immune system, and open them up to possible infections and stuff. So those are the ones that tend to be the ones I have to inject forever, or the unilateral ones.
Depends on how frequent too. So like if you're looking at like how often is this unilateral eye flaring, and what is the degree of the inflammation. So if they're coming in and they're 4+ cell and this is happening every like 2 months, get them off steroids. Like they need immunosuppression there, right? Because every time, I use this analogy all the time that you used earlier. Uveitis is a fire. Every time that fire is lit, it burns the eye.
Mm-hmm.
And so are you willing to accept damage every 2 to 3 months in this eye, or do you want to try to prevent the flaring happening? So what the patient's interested in may be local steroids, which is a great choice. But if they're not interested in local steroids at the risk of glaucoma, or their nerve health isn't great, or they are a young patient and you're worried about them developing a cataract or other issues, then like go towards IMT. Like there's so many different treatment choices that we have now. There's so many different things, but this really
And that's the other thing too, is so if I have had to escalate beyond drops or STK to an Ozurdex, the first one, it doesn't automatically buy them a second one. If it works and works well, and they come back at 12 weeks and they look better than they did at their 6-week pressure check, which was better than they did when they put it in there, sometimes I'll let that one ride and I'll tell them, let's just see how much effect we get out of this. And if it never recurs, then we just watch it. And like you said, if it's something that by the time they show up at 12 weeks, you see their OCT going back the other direction from the improvement you got, then you know they're on the train. And so populations vary. In South Carolina, there are a lot of people who are very skeptical about all things medicine, and everything is met with a lot of questions. And I get a lot of, you want to do what? You know, and then you have to break it down and explain it to them. And then you have to say, well, I think I need to send you to a rheumatologist. And some people you have to explain what that is. Some people you have to explain why you're doing it. And if you do, and they say, you want me to be on a medicine for how long? You're like, I don't know. Like forever, maybe. What happens if I take it? You might get sick. So it's a big thing. And so tailoring your conversation towards educating and helping them understand why you're doing what you're doing makes your life a whole lot easier. It'll leave with fewer questions and much better compliance if they understand this isn't, I thought you cured me, doc. Like, no, that's not how this goes. This is your genetics. This is the way your body was made, and we're not changing that. This is a ophthalmic manifestation of a systemic disease, right? This is not an eyeball problem. This is a all of you problem, and so we have to be vigilant. So making sure they understand those things has a big role. Yes? No.
The idea behind it is a couple things. One is the data on it I don't think is great. I don't think it works well for patients. The other idea is you're essentially are you giving people steroids ultimately by affecting their pituitary axis and essentially stimulating that pathway anyways. But I just don't think the data on it is great.
You mentioned certain drugs for your uveitic patients with regards to pressure.
Mm-hmm.
How about the patients that are on Ozurdex? Is there certain drugs that are better for pressure control than others when you're putting that much Ozurdex in people's eyes?
Personally, I don't like letting patients leave the office without knowing something's going to bring their pressure down. And so what I do is if there's no contraindication or allergy, I just put a drop of Cosopt and Brimonidine in after they come back at 6 weeks with a pressure of 34 and make sure 30 minutes later it's trending down. And then if that's the case, I'll leave them on that and then see what their pressure is at the 12-week period when it's washing out on both agents. Then I might take one away when they come back at their next 6 weeks pressure check. And if the pressure's good, leave them on that, like leave them on Cosopt or something. And then sometimes what we'll do is have them stop both or whatever they're on, like 3 or 4 days before they come in for their next visit to see if it's still gonna hold and stay down. The other thing too is always, and hate it, gonio your patients. I can't tell you how many times they've said his pressure's 34 and they're like, it's another Ozurdex pressure spike, because that's the one thing it is notorious for. But you go in and look, and there's NVA. And so those patients, you get an angiogram on, and they've had the disease so long that they're getting peripheral ischemia. And so they get an anti-VEGF. And I'll alternate every 6 weeks anti-VEGF Ozurdex for a few, maybe 3. And then I get some PRP in there so that then we hopefully don't have to deal with that neovascular pressure spike. So it depends on the mechanism. If it's truly steroid-induced, then I'll start them on Cosopt and Brimonidine because I'm a caveman. And those are the ones that I had when I was a resident. When it's refractory or not improving, Rocklatan works really, really good. It's just I have a lot of people that can't get access. So my population, Cosopt and Brimonidine are good because I've got them, they're cheap, and the patients can actually get them. They're okay. I mean, they don't work fast, right? And they can be a barrier to getting your CME resolved, so it's not preferred. But I have a lot of folks that had long-standing open-angle glaucoma before, and if there's no CME or I'm not having any trouble managing the disease, I'll leave them on it. but it's not something you'd want to just start with because it's not going to start working immediately. I want something that's going to start bringing the pressure down now. Yes?
Is the coverage better now through this fluorescent plans?
The coverage is better, and you have to have the right diagnosis is important. And I find how you choose to describe stuff can often help your patients get what they need to be well. That's all I'm going to say. The other thing, too, that they don't make YUTIQ and it's all Illuvian now. But the reps, when they come around, I tell them, they ask me what I need, and I say, just make sure that my patients who can't afford it can get it. And so they have they're able to get some charity cases done, things like that. So, yeah, I mean, I don't have a barrier to it. And the only time that ever gets kicked back, I just call and say, this is what this is, and this is how it's, like, their quality of life is affected by it, and their frequency of visits and all these things. And usually the physician who works for the insurance company green lights it, if you got to do like a peer-to-peer or something. Yes?
This is a basic question, but every time I order serology, it includes ANA. What information do I really get from it?
Nothing. In my opinion, nothing. What do you think?
ANA, 40% of the population will have a positive ANA, and so the likelihood that uveitis is actually causing your lupus is very unlikely because you can't make a clinical diagnosis with lupus based off of ANA or blood testing alone. You have to meet certain clinical criteria in order to have that, and so the presence of uveitis being the only thing that a patient with lupus is having is very unlikely. So this is where a great review of systems is going to help you to determine the likelihood, your predicted probability of you actually needing an ANA in this clinical situation. Uveitis also typically does not cause, or ANA lupus does not typically cause uveitis. You're looking at specific, and this is the tiered approach that you were talking about, is an ANA is typically going to cause scleritis or orbital-like connective tissue diseases or an occlusive vasculitis in the eye. It's less likely to cause alone an anterior uveitis or an intermediate or posterior uveitis in the absence of those other findings there. And so if you're going to get an ANA, there's a couple of clinical scenarios that would be great, like JAA, right? Like, so if you're screening a pediatric population, they need it for other reasons, not because you're making a diagnosis, but how quickly are you following this patient based off of ANA levels and other things like that. And then the flip side of that would also just be if an individual has any of the signs or symptoms that we're looking at, great, you're going to order it, but get a reflex. So a lot of times the labs will get a reflex, and you'll get much more specific rather than sensitive testing, such as like your Smith, your double-stranded DNA, RNP, other things that are much more likely to be present in a mixed connective tissue disease, such as like lupus.
What he said. Any other questions about uveitis? Any stories, anything? I'm sorry? No, I don't manage anything systemic in my patients other than PO steroids if I have to. Like I told you guys, God smiled on me when a rheumatologist moved in next door. Dr. Lee Day, he's awesome. So if you have to know, having a close relationship, sharing a cell phone number with a rheumatologist is invaluable. And we tell all our new associates, we introduce them to the rheumatologist. I've kind of drafted Lee into my education component for my fellowship program to do some teaching so my fellows know who he is. This is because especially if you have a rheumatologist who wants to manage this type of disease, they're happy to see these patients and help you co-manage because they don't want them to come to them too late to help too, right? So yeah, you want it to be as fast as possible. If you think you're gonna need them, if you even think about it, as Marla Price used to say that, if you think about it, do it. So if you think you're gonna need them, call them in. And even, what's the worst that could happen? They go, you got it, they don't need anything, right? Anything else? Yeah. Awesome. Awesome. Yeah, and I have had patients who have, I don't know if you've run into this, but some of my patients who have gotten that from their comprehensive or from their glaucoma specialist wind up losing the coverage somehow, or they were on it and then they lose it. It's something they have to keep up with on a regular basis. Yeah. That's good. That's good. For convenience sake, Cosopt and bromonidine are great. They're awesome drugs. It's pretty rare that between those three agents in those two drops that it doesn't do what I need it to do if the reason is just steroid induced. Usually if those don't do it, then I've stopped and I go, what am I missing here? Something else. Go back and re-gonio, make sure that their synechia haven't zipped down posteriorly, something to that effect. But yeah, that is good intel. All right. Well, this was great. This was a lot of fun. Thank you all for your time.
Thank you, Dr. Hypes. We do have just a few minutes before our planned start time for the retina panel. That will also allow us to rearrange the furniture here on the stand in preparation for our retina panel. So we'll plan on reconvening here right at 11 o'clock to begin that panel. Thank you.
Yeah, they're all good. I just noticed that this battery wasn't full, so I don't want to risk it. I just make sure all the batteries are good to go. But yeah, they should all be on. I might have to turn the volume up, but you can use them, any of them right now.
Okay.
Is it working?
Hello, hello. All right. Believe it or not, this is actually 11 o'clock, like I said before, because I can't admit that I was so wrong and so far off on my timing. But we're going to go ahead and plan and get started here at the top of the hour. We'll invite back up to the stand here our previous lecturers, Dr. Strand and Dr. Hypes. They will be joined by Dr. Sutherland. Dr. Lilia Sutherland completed her medical school training at the Edward Via College of Osteopathic Medicine. Then she completed her ophthalmology residency through Michigan State University at Metro Health in Grand Rapids. Following her residency, she completed a 2-year vitreoretinal surgery fellowship with our practice, not our practice, but retina specialists of Michigan in Grand Rapids. So we invite her to join us at the panel. This panel is going to be kind of an informal discussion and opportunity to talk through a few topics as suggested by our panelists, a few ideas that we had as we were talking about what would most greatly benefit the general ophthalmologist and become a resource for you. We do have a microphone stand here in this aisle. I'll also be standing down here on the floor as a moderator, and if there are questions throughout the audience, if you don't wish to come up to the stand microphone to ask the question, I can come and meet you. But we'll have a few slides just as discussion generators and prompts here that we'll go through together as we talk. But feel free to wander away from our suggested topics if you have questions directly for our panel, and we'll be able to open things up as we go along. So thank you, and we'll just get started with one of our first questions. As we were discussing potential topics, a question came up. What cases do we see as retina specialists on referral that we feel could be maybe collaborative or empowering our colleagues to observe and watch on their own? Dr. Hypes or Dr. Strand or Dr. Sutherland, tell us about maybe peripheral retina changes that you see that tend to be observation decisions.
So a lot of times cataract surgeons will refer a peripheral retinal degenerations like lattice degenerations with atrophic holes for cataract clearance. And I think that is a valid referral. However, once it's been validated by me that it's okay to monitor, I am comfortable returning those patients back to primary ophthalmologists for monitoring, especially if treatment has been done. The other ones is dry macular degeneration. checkups. Like sometimes dry macular degeneration patients can have atrophic cysts or the vitelliform lesions that are quite often confused with fluid or CNV. Again, once that has been validated by a retinal specialist, you might notice collapsing vitelliform lesion that again looks like pseudofluid, yet that does not need treatment. That is also, I'm perfectly fine having general ophthalmologists watching those and or geographic atrophy.
Choroidal nevi. I think if it's small, it's flat, there's no suspicious characteristics, just you could watch that. I'm not going to do anything with that except tell them everything you've already told them. And, you know, I think the one thing we have to consider is that patients get really scared when they get sent to someone for a possible tumor in their eye. If it's suspicious, by all means. If it's thick, if there's fluid, if there's symptoms of orange pigment and it's close to the nerve, send it. But, you know, a peripheral flat nevus with drusen on it, I believe in my heart that those patients are going to be just fine. And it's rare for a melanoma to come from those anyway. So it would be a de novo thing if it were to happen. So just monitor those in addition to everything Dr. Sutherland said, if you don't mind. Thanks.
I agree with the above statements here. I don't know if this puppy's working. But question back for y'all in the audience too, what's your take on CSR, central serous chorioretinopathy as well? What do you do as far as you get these referrals in management? Do you guys continue to hold on to these patients? Do you guys follow them for the long term or have them back if they have recurrences and consider like photodynamic therapy? Because this is one of these things where someone will develop CSR, very mild, goes away with observation, and then every time someone has subretinal fluid reaccumulating, like in the absence of like forming a CNVM, like do you prefer to see these patients back or just say, hey, why don't you guys just monitor these patients, especially if they have just slam dunk pachychoroidal disease?
If the fluid resolves, I stop following them.
Okay.
I do follow them until the fluid resolution because I want to make sure at least it's heading in the right direction. A lot of times patients will know themselves when it recurs and they'll come back to you. I kind of started to back away from this kind of, I would say paternalistic, but it would be in my case maternal approach to keep bringing them back. Some of these things are on the patient to report changes in vision to you as well.
I just had, the first time this has happened, because I see a fair amount of CSR, I had a guy that wound up, the fluid didn't resolve. We ended up doing PDT. He had lived with the fluid for a very long time before he even sought care because he didn't want to see a physician at all. His other eye was seeing very well. And the PDT worked great. It resolved the fluid. It never came back. And then, this was about 2 years ago. And then he called to be seen because he assumed his fellow eye just had subretinal fluid because it appeared similar to him. And he showed up and he had a massive submacular hemorrhage from a CNVM, secondary to the CSR most likely. But he ignored the symptoms because he assumed it was just that. So I think the biggest thing, this was an individual who wasn't going to seek out, he doesn't routinely see an ophthalmologist anyway. So the one thing I would say is if we're not seeing them, someone has to. So it depends on who their primary eye care provider is. I've got patients who are, they see some of my comprehensive colleagues once a year, predictably, they're reliable. Those people are fine, but some of those folks that, you know, they might go to lens crafters once every 5 years, that's it. And then those are the people that I tend to want to hang on to. Say, let me just put out a 1 year here so we can touch base. And also, too, for ease of access to getting back into the clinic. If I PRN someone and a year goes by, it's a lot harder for them to get back in than if I make an appointment for a year and then they miss it by a week and call. My office is going to go, oh yeah, he just missed his 1 year, let's make it happen, as opposed to coming in as a functionally new patient, even though it's only been a year or so.
Since it was brought up, we'll share. Okay, thank you. Since it was brought up, let's talk a little bit about PDT here. How frequently are you using it? What role does it have in your management decisions? And how soon, if you are doing it, would you recommend PDT?
I don't jump to it right away for multiple reasons. First of all, we know that 95% of the cases of CSR will resolve on their own. 30% recurrence rate, though, so it's those people who keep recurring and subfoveally, because we do know that RP damage will eventually result in vision loss. And if we can identify the leaking point, of course, then I'll do the PDT. But I can probably count on one hand how much I do per year now. I'll probably try everything else before I do PDT, and partly is insurance coverage. Insurance does not cover Visidyne for the CSR diagnosis, so you have to actually almost finagle a diagnosis, make it a CNV for the insurance to cover it, at least in Michigan. So it is covered for neovascular AMD, but it is not covered for CSR, which is the primary use of the Visidyne.
I tend to agree, probably a handful of cases a year, chronic recurrent CSR, that are noticing a change, guided by FA for treatment. I think we do see pretty good results, but we run into the same challenges. Number one, getting reimbursements, and then two, a lot of retina specialists don't even have access to PDT because these machines aren't even being, produced really generally anymore. But definitely think that there is a role, but again, for chronic and recurrent cases.
My practice situation is a little bit different. We're the only retina group that covers a third of all of central South Carolina refers to our group. We have patients that come even from more rural areas of Georgia and North Carolina. And we have a teaching program. We train retina specialists. I have a partner who came through, I don't know, probably 12 to 15 years before I did, who came in right as the anti-VEGF wave was taking off, and has somehow managed to go his entire career without ever doing a PDT as a retina specialist, because he didn't get in early enough when it was the standard, and he came in when the injections were taken off, that it just never came up. And where he was practicing, I guess the CSR was infrequent enough. But because of our coverage area, we do see a fair amount of CSR. None of my seasoned partners want to do it, because it's a pain and it takes time, and you have to coordinate it into a busy schedule, and we have to have one of our schedulers who's an RN to do the dye and everything. But for me and my motivation to train, I'm actively looking for perfect CSR candidates, because I want my fellows to do some, because I refuse to say they've graduated without ever doing one, which is bananas. But it has to be recurrent. And not just recurrent, but recurrent in a meaningful way, visually symptomatic, or showing some like central anatomic, you have to, But for wet AMD, believe it or not, as a retina specialist, I don't want to do injections. I want them all to be well. And so if it's an eccentric CNVM especially, I think that's a slam dunk to try to see if we can get them off. Even if it's non-central, sometimes I'll just laser a CNVM, but they tend to recur like a year or two later. But I'll still do PDT for eccentric CNVMs, just so that the thought of doing that stays around, because otherwise that treating CNVM with PDT will disappear completely, because it's too easy to just be an injection donkey and just see fluid and inject fluid all day and not put your thinking cap on. And the meaningful difference it makes in your patient's quality of life to go, Dr. So-and-so that saw me, in whatever state I just moved from, injected me every 4 weeks, and then you see a little eccentric thing, you're like, I want to try something. And then you get them off their shots. They think you're, like I said, a wizard. I mean, it's incredible. So keeping that alive, I think, has a lot of utility still, and I don't believe it's dead at all, and I think we need to, but it will be if we don't actively make it happen.
Dr. Scorin, do you want to come up to the microphone so we can all hear you? Thank you.
It's not that smart of a question. It's a comment. It's interesting because when you started talking about PDT, I thought, does anybody ever use that anymore? Because in our area, the same thing, that retina people have stopped using it, and as a generalist, I just thought, well, maybe it's just disappeared. Something that's timed itself out. But it's nice to know that it's still alive someplace in Carolinas.
It works.
Well, I'm not saying it doesn't work. I'm just saying I think it's the logistics of using it. I think that's what it is. So.
People just have been waiting.
Sadly, it's also money. Like the lasers disappearing and the new ones that coming out where they charge the click fee,
Yeah.
it becomes cost prohibitive for the new specialists to start doing it. Go ahead. Yeah.
Yeah, do we have another
Adam?
question?
Yeah, can I change topic a little bit? You don't mind?
Absolutely.
So, as a comprehensive, we're kind of in this, in my area, I don't have any retina specialists that are using Syfovre or any of these geographic atrophy medications, but patients are seeing them FDA-approved commercials, you know. I was just wondering if you guys are utilizing these, whether you think that if you have a patient who really wants it, but you don't have a retina specialist who likes it, should I be looking for other retina specialists, or should I trust my retina specialist?
Did you look at the slideshow ahead of time?
Not a plant.
Thanks for
Not a
prompting
plant.
us.
I think two parts there, Adam. I think first is if you're really concerned about your patient and they've seen a retina specialist and they're not on board with saying, I want to treat this patient, but the patient is very highly motivated to get that treatment, then I think seeking a second opinion, because they should have access to treatment that's FDA approved. On the other hand, I gave a talk a couple of years ago here when these complement inhibitors came out. I'm not the greatest fan of complement inhibitors in the sense that I think that the data is pretty poor. When we look at pegcetacoplan, the Oaks and Derby trials, I don't think the drug should have ever been FDA approved based on their trials. They've got the Gale study, which was a 3-year extension study, and now they have 5-year data. And I think the biggest thing to relay here is when you review the 5-year data, which they really don't publicly disclose, is that patients who either got sham injection or actual injection, they still lost about the same amount of vision. So I do treat patients with complement inhibitors, but these are patients who are very highly motivated, who are saying, yes, I'm willing to do everything after going over the risks, benefits, and alternatives, you know, of this treatment. So I think it's something that's very, very controversial, and I know everyone has their own opinions, but I think if someone is highly motivated and you have a treatment option that is available, that you should always guide them in the right direction if they're trying to get it.
I think that it's important to choose the patients that the literature they've given us to work with fall in that framework to maximize theoretical benefit and minimize risk. So these are patients who have, you're not going to inject, you want to prevent vision loss in these patients. So I would start it in someone who has eccentric geographic atrophy that on their autofluorescence has a hyperreflective border that I've seen visit to visit enlargement. And also want to have someone who doesn't have a crowded disc to minimize the risk of NAION. I don't have a strong preference, one drug over the other. The data is fairly similar. There were some early issues with intraocular inflammation with Syfovre that some of the issues with, they thought it had to do with the syringe they gave you or the needle. So last year, the incidence of like 300,000 injections might have had 1 or 2 cases. So I usually ask them which commercial they saw most recently, and just let that guide me. No, I'm just kidding. But I have very few patients on it. I have a lot of GA patients. They have to be the perfect patient, highly motivated. And a lot of times what you hear is, my mom had to get the shots. And so I think, you know what I mean? So I saw mom go blind. Or they've already lost on one side. They're already towards end-stage disease. But it's because it's very easy, like I said, to be an injection donkey and go, you got GA now, so do a shot. So that's not the way to approach that.
I think that's the big thing is, like, I have a lot of GA patients too, and I try to keep them out of your office because I know there's nothing you can do for these patients. But it's figuring out the balance of when they're seeing these commercials, like, do they deserve at least seeing you for that opinion? But that's
Sure.
That's going to turn into a real overburden.
Because you're not going to do it. I think the autofluorescence is critical if you're going to be selective about how you apply these drugs to your practice, and you're not going to do an autofluorescence on these people. We do them all day, every day. And so the other thing too is it doesn't have to be on you to make that decision for the patient if you just let us do our job and explain why they're not a good candidate. I have more conversations with people why they're not a good candidate for it and help them understand just because it's on the commercial doesn't mean you need it. The other thing too is when you're looking at geographic atrophy, if it's not rapidly progressing, there's likely not going to be any benefit to the drug anyways. I explained to the patients that this is not going to restore any vision. We're trying to hang on to what we have as long as possible until something better gets here. So it's not It's not the best we could do or the best we're going to be able to do, but it's better than what we had. But if you're not seeing progression over, 6-month visits and it's just kind of hanging out there, I wouldn't worry about those people. The other thing too is the geographic atrophy configuration that comes from like a drusenoid PED that collapses. Those don't expand like the typical geographic atrophy lesions that ultimately take over the whole macula. You'll get the dropout there in GA, but it doesn't behave like that. So that's someone who you would say there's probably very limited benefit. And if someone's got a crowded disc, I will not do it at all because I don't want to be the reason that they get a NAION.
Yeah, I kind of have, my approach has evolved quite a bit. Initially when the medicine got approved, I was skeptical because the data was rather poor, I thought. Well, the data was, as far as presentation was fine, but the benefits seemed to be poor because when you compared reduction of rate by, at 1 year, 20% reduction rate of growth of GA, well, that's the data we have with AREDS, right? That's kind of what it does. And then more and more data kept coming out each year. And also, I do agree that patients do deserve to, it's an FDA-approved treatment. You cannot withhold treatment from them, especially once it was deemed safe. When more information came out regarding inflammation, that it was well controlled, they changed, and I think it partly was the needles that they use. They now comes, like Syfovre comes with needle that they have. I think it actually maybe made a difference. Then, the data kept coming out. The rate of GA expansion is actually, the benefit is there at 3 years, 4 years, is up to 40% slowing down of the GA rate. And if you can put the next slide, Scott, that I have. I started doing the analysis with my patients who, either before or after the treatment. Do you have a pointer? I think your clicker has a pointer. Which one is it? Oh, the laser. So what we do now with Heidelberg, we measure on autofluorescence, we measure the area of autofluorescence, and this is the patient that, and then it kind of plots it. It's like the AI tool that Heidelberg is trying to incorporate. For example, this patient is, he has neovascular AMD in one eye, and he has GA in the other eye. And I started treating him at this point right here. And you can see that the rate of progression has decreased. The slope has become less steep. And in fact, here it shows that it actually has significantly slowed down. I actually generated this because an insurance company stopped covering Syfovre for this patient, saying, you, at your annual exam, you did not mention that this patient benefits or the rate of GA expansion has slowed down. So we have generated this graph from all of his images. And sorry, folks, I'll show you on there, like this is the starting point for treatment. And, to provide to the insurance that it is helping. So it's still not for everybody, I agree. Things like proximity to the fovea, the involvement of the other eye, multifocal versus non-multifocal. We know that multifocal GAs actually expands faster. If it has the hyper-autofluorescent rim around the hypo-autofluorescence area, then we know that that's the active area of photoreceptor degeneration and RPE degeneration. So you kind of present the data, and I literally tell the patients, they don't need to see this picture. I was like, well, we have medicine that, will slow down your degeneration. It will make it better. It will make you lose vision, not at this rate, but at this rate. And they make the decision at that point. The other part that has become a huge player for us, and you folks as general ophthalmologists should be way aware of this, no financial interest, but there was an assistance program called Good Days that helped patients with copay for the medication. And once it vanished, it has become a tough pill for them to swallow because it's a $400 copay for the medicine that doesn't improve their vision, just slows it down a little bit. So that's another kind of thing that, unfortunately, us as physicians have to have the discussion with the patients is money, like, because that falls on them, and then they will be really mad if they have to shell out $400 each visit.
Did you see a progression in the GA problem after stopping the medication?
Yes, I do actually have the patients who, once it becomes subfoveal involvement, a lot of times, or their vision drops down to 2400, I advise them to discontinue the injections. And on those patients, after I follow them, I do the same analysis, and it picks back up. Yeah, I mean, again, it's anecdotal. It's on my patients only, and of whatever. But I have seen where the curve gets steep again.
Random question for the panel here too. We know a risk of this class of medications is the formation of choroidal neovascular membranes. Among the patients that you've been treating, have you seen development of CNVM, and how has that changed your management?
I have, and that's again one of those that I discuss with the patient, but most of the patients choose to continue. We just start anti-VEGF and alternate anti-VEGF and the complement inhibitor.
So you do separate visits?
I do. I don't inject on the same day because it's too much pressure spike for those, I feel like.
I had a patient who, like I said, I don't have many on it. They've got to be the perfect patient. So I might do 3 a week, right? But I did have a lady who came with actively treated wet AMD and GA. She was on both elsewhere, and she came to me. And she ultimately wanted to just discontinue the GA treatment to maintain the benefit of the anti-VEGF, which I thought was a reasonable thing to do. I have one patient who has inactive wet AMD in an eye with geographic atrophy that we stopped there. I did treat and extend, and they haven't needed an injection in a few years. And so I kind of cautioned against that, and I haven't seen a reactivation in her, which I think is fortunate. There is a physician that I'm aware of, and I would agree to never inject both in the same, because it's double the volume when you're doing Syfovre. It's 0.1 cc's. It's a lot. It's thick. Pressure goes sky high. But has started doing the port delivery system so that he can at least get them off their monthly anti-VEGF injections when they start moving over to the complement inhibitor. There's port delivery systems, a port you implant in pars plana and refill it every 6 months with anti-VEGF, so you're not having to bing bong back and forth. I hope I never find myself in the situation where I have to think that, do I need to do that? But I put a few Susvimos in for just wet AMD in general, but there are ways to kind of manage that. But.
Dr. Hypes, you kind of answered my question a little bit already. More of a comment. It's over here, down here. Court Webster, one of the residents at the Taylor program in Michigan. We do our rotation at ARC, Associated Retinal Consultants in Detroit, and there's a couple providers there that actually, and you kind of commented on it, but they do a Syfovre injection and the anti-VEGF simultaneously, and oftentimes if the patient, they'll do an AC paracentesis and kind of tap if the pressure goes too high, but their thought is, and even if they haven't even started to develop a CNV at all, like they will just do that in theory to prevent that choroidal neovascularization from happening. What are your thoughts on that, and if you've seen that done before?
I would check to see if those patients are part of like an institute-sponsored trial that they're looking at their data so that they can present that. ARC is pretty prolific in retinal research, and so that might be why you're seeing that practice behavior. I have not seen anybody prophylactically doing that. Mm-hmm. There are plenty of people who will inject both on the same day, though. You just have to do an AC paracentesis, or you'll raise their pressure to 60.
Yeah, gotcha.
And put them in LP for a few minutes.
Yeah, I haven't seen done prophylactically either.
Right before we move on from this one topic, because I think that this will also be kind of insightful, are there, for your practice, relative exclusion criteria in a patient who is asking for anti-complement therapy? Like, is there a condition or comorbidity, an age limit, a vision limit, where you'll say this is just not the right therapy for you?
I think the data is most compelling the longer you're on it. So if you're already center involving, it's probably too late. if there's no hyperreflective ring on autofluorescence, if the nerve is crowded, or if they're open angle glaucoma and cupped too, because I don't want to spike their pressure every 8 weeks. And I'll only do it every 8 weeks, even though the data can be used every 4. I feel like you minimize your risk, and the difference in the trend curve is not too dissimilar, at least with this level of data that we have.
And also the rate of macular neovascular membrane is lower at the 8-week injection interval. So I think that's another compelling evidence to stay within that 6 to 8 weeks.
Thank you very much. Any other questions before we move on to another topic? Let's say that it's Friday afternoon, you're in clinic ready to wrap up for the weekend. This is the classic scenario, right? And you get a phone call from a referring provider saying that there's a retina detachment. How does the clinical scenario determine your pursuit of definitive therapy for these patients, and does OR access or other situations affect that clinical decision-making process?
So I think it's a bigger topic among retina specialists. Things that get brought up at the ASRS is access to OR. There's been a shift more towards surgeries at ASCs, less surgery at hospitals. And so this does come up, and not infrequently, but I think a lot of times, obviously if somebody's coming in with a macula off detachment, and they have something that we can treat with like a pneumatic retinopexy. I'm a big fan of pneumatic retinopexy with staged laser cryo or a staged pars plana vitrectomy. And you can reattach a lot of eyes just with this technique alone. So I think having that in the back pocket, heavy on pneumatics even during the week, because you can save people from the OR. I think in the event that someone has a MAC on detachment, and it's something that may progress over the weekend, and I don't have access, I will talk to them about a referral. But typically in these cases from where we live, it would be sending them 2 hours away to like Vanderbilt, Louisville, or St. Louis. And most of the time, even in the retina community at the academic centers, they're going to see that physician be like, yeah, we're still going to wait until Monday to operate anyway. So there's a little bit of a paradigm shift. I think getting the retina attached as soon as possible is always the best. But I'm really heavy even during the week. If it's a Friday, I have no problem putting a pneumatic in, even if just to stabilize the retina and position the patient.
Right when I was a fellow, it was Charlie Wyckoff and the Houston group published this interesting paper about 72 hours for a MAC on detachment for time to repair. And I was very confused as to why they wanted to look at 72-hour outcomes, and that's because that's the time from Friday afternoon to Monday morning. You fall within that range. And so the adage was, when I first started doing this, was if it was a MAC on detachment, you had 3 days to fix it. If it was a MAC off detachment, you had 2 weeks to fix it. And both of those are complete crap. If I was MAC on or MAC off, I would want someone to fix me right now, because the sooner it gets fixed, the better the outcome, unless there's some weird intervening variable that you need to let something chill out, like a hemorrhage if it's traumatic, whatever. So Friday afternoon, I'm fortunate. I can get into the OR whenever I want to. I operate at a hospital with an outpatient surgery center, and it was a new ownership of the hospital, and we were the first people to sign on, and so they're very generous and let us have what we want. And I don't want to say I started a fellowship just so I could have someone take care of this stuff on the weekends for me, and I just had to show up and watch the case. But if you have trainees, that is a great way to help jump some of these hurdles. Just for the first time, though, because we had a journal club on this just like 2 years ago, it's relatively new to just inject gas in the eye, do nothing else to temporize them until you can get them to the OR. And so I just for the first time did that, and a guy had a big bolus MAC off detachment on a Friday. I operate on a Wednesday. I called him on Monday, and he said he was already could see again, and he was really happy. I said, we still have to fix this. It's not done. If I'm going to do a pneumatic retinopexy alone, and status of the fellow eye always plays a strong role in this, right? But if I'm going to do pneumatic alone, if I can, I do cryo at that time. I don't like doing it staged because your view can be really unpredictable. You can get a lot of glare from the gas. If you have fish eggs, you might not be able to position the patient the way you want after they've reattached to get your treatment in there. So if I can reapproximate or get close to where I know I'm getting at least some good cryo, and you can always add laser later, but I want to do cryo and do the gas at the same time.
So several factors affect this. One of them is the longevity of the detachment. If I see somebody on Friday, they were seen on Monday, they were MAC on, and they, for some reason, got in to see me on Friday, and they're still MAC on, the chances are it's not going to move before Monday. The best thing to do is position them on the side of the detachment down. You know, if it's a superior temporal detachment, you lay them on that side. You tell them they'll have a pretty bad weekend because they'll have to lay in that position to keep the fluid away from the macula. The other thing is the position of the brakes and position of detachment. So we do know for pneumatic retinopexy, traditionally it's been you know, one brake, or if there's two brakes, they're within 2 clock hours of each other. That has been thrown out of the window by Canadians who do pneumatics. My partner did training in Canada, University of Toronto, and they pneumaticked everything because they have no OR time, and they actually have great data supporting pneumatic that might require patients stand upside down, but they did a great job with that. I'm, in my practice, pretty strict as far as when I offer patients pneumatic, because the failure rate is truly, you know, the reported failure rate is 30% of pneumatic, but in reality, in real life, it's up to 40, like 60% of reattachment. I think putting the bubble to tamponade and save the macula until Monday, I think it's a great idea. A lot of my partners do that. I have not had a chance to do that yet, but it's definitely you know, one of the things that if you're getting into the eye anyways, of course, then you can, if you are doing primary buccal, that goes out of the window. If it's a phakic patient and you were planning on doing just the buccal, you're not going to be able to do that. You'll have to get in the eye to get that gas out. You know, all of those things play a role, and MAC on, MAC off status is definitely, you know, I think it's fine to wait for MAC off from Friday to Monday. MAC on, you'll have to be creative and see if that detachment is moving rapidly, and if it's like fovea splitting, or if it's like a millimeter from the fovea, because you know that vision will never be the same.
I think that's a great point. She was alluding to Raj Mooney in Canada, who's kind of pioneered and brought back pneumatic retinopexy. And they do the craziest things and have high rates of success. And what you alluded to is there was just a study that was published that people who don't do a large number of pneumatics, failure rate can be up to like 50%. So I think it's great. And then the other point too is when you're looking at these detachments too, Raj Mooney talks about regulated and unregulated retinal detachments. And what I mean by that is regulated retinal detachments are typically these younger phakic patients, high myopic, typically have an inferior detachment with lattice and holes, and they may have like a demarcation line and they're slowly breaking through to the macula. These typically can wait as well too, right? Because in a regulated detachment, you have a functioning RPE pump that's keeping things at equilibrium versus, let's say, your older adult who has a PVD and a large retinal tear that's very dysregulated. These retinas behave very differently, and those typically can wait as well. Especially they do great with just primary buckle, and primary buckling I think is a great tool. Do it all the time. That was
I tell my fellows this: retina is not a lifestyle specialty, and the more you try to make it one, the worse you might enjoy your free time better, but your patients will wind up worse for it. And I want to fix them now, because if I wait till Monday, there's going to be 3 more. I don't want 4, and so I kind of have to bail out the boat as the water comes in, and that's another rationale. I would want mine fixed as fast as possible, and I don't know what's coming, what else I'm going to get called on Saturday. So I'd rather just knock it out at the end of clinic, and if I can, right? But like I said, I have the benefit of ease of access. So.
Ready for the next topic? Oh. All right, I think Dr. Hypes is really excited about this one. All right. What should I know as a general ophthalmologist about photobiomodulation therapy?
So this is all new, still a little bit controversial based on the light sight studies. This system was approved over in Europe. Now it's a Class 2 FDA device that's approved in the US, and I think the indications that I'm just spitting off the top of my head It's for patients with vision better than 20/70 and the appearance of intermediate drusen, so size of like, 62 microns to like 125 microns. And then additionally, extrafoveal geographic atrophy are the indications.
I think that you undersold your spitballing.
I don't know.
Just
I
saying.
blacked out for a second there. Where am I? But I think with this, a little bit controversial here too. And in their studies, basically, they showed with the treatment series, basically, 9 treatments over, a 2-week period or so that can be repeated. They showed that these individuals had an improvement of somewhere between like 5 to 7 letters of visual acuity. I think still really controversial. The other things are this device just got by Elcon from the original manufacturer, and the price initially for this unit was very high, like $68,000, and it has a click fee for it. Elcon bought this unit, and initially their list price was like $100,000. They've come down like a little bit, and a click fee of like $30 per treatment. We're not offering it at our clinic. We're looking into it, but I think it's a huge thing as far as workflow to busy retina clinics, how you can do this. I think the greatest application, because I'm not necessarily too concerned about just these patients with intermediate AMD. I'm more concerned about a non-invasive treatment for geographic atrophy, and I'm looking more forward to data and studies that are going on that are looking at prevention of GA progression without a invasive therapy like complement inhibitors, but that's just my 2 cents.
I think you summarized it really well. From what I also recall, the light side first trial had conflict of interest, so they kind of threw that data out of the window too. That was not a reliable data. So then they reanalyzed it in 2 and 3, and I think the vision gain, they actually looked at vision gain, and it was like 3.5 letters versus 5.2 letters, with treatment. So it is not enough for me to implement that treatment and not to recommend that treatment right now to the patients. But unfortunately, I believe a lot of optometry is getting that, which is, that's something that you all will see. Yeah. Optometrists are getting that, and they are offering it to the patients. And that's where a lot of my patients come in. It's like, hey, my optometrist offered this treatment to me, and I say, there's no good data. The studies actually the sample size is very small. It's not like these, and a lot of them are not multi-center. I think they were like single-center studies, and they had, I think at most 70 patients. It was just something the sample size was very small.
How is this being delivered?
Yeah, so basically it's like a machine. You just basically think it's like, 90 seconds per eye treatment. You're just looking at this light, and they just stare at the light and put a button.
It's not like because there was a laser treatment that came out 6 or 7 years ago briefly that it was even marketed to comprehensive where you could treat focal macular degeneration dry and early intermediate that had crazy high, ended up in the real world having real high CMV issues. What am I thinking of there?
I'm not sure what you're thinking of. I might have missed that with my training wave. But I think the fiscal efficacy of photobiomodulation has been proven. And when fiscal efficacy outperforms clinical efficacy, I'm very skeptical. For the medical students, always leave room for the possibility that you're wrong. Time shows us things can, over time, become more compelling. I would love nothing more than for us to find out that photobiomodulation therapy, if you get them on it at the right time, at 10 years, they have significantly better vision, lower rates of wet AMD. It's all too new to get excited about, and there's too big of a push to get people making money off of it that I want it around at all. However, I think if anybody can keep an AMD patient from making it to the retina specialist, I didn't see a lot of harm or negative components with it. I don't care, but it's not going to be in my office, not yet anyways.
I talked about just changing the fluorescent lighting in our office. so we can get red, yellow, and some infrared spectrum. And they just sit in the dilating room and they just stare like that. So that's something I'm entertaining, but they haven't given me the credit card to go to Lowe's yet. So
So the one thing that in the study, some of the variables that they were looking at, like drusen height and things, we don't factor in as correlative for vision and long-term changes in the disease anyways. And there were some of the variables that they looked at in the sham category that outperformed the treatment category. Right, so, no, that's gonna be a no for me.
Plus natural progression of drusen, it changes on its own. Anyways, it kind of waxes wings. There's morphing PEDs and stuff, so that's a natural progression of the disease.
We have one question.
great question. So it depends state by state and carrier. There are now carriers that are reimbursing for this. And I think, let's say like maybe like $200 to $300 per treatment, you know, per eye, right? But I don't know of any commercial payers who are paying for it. And I think the other risk, you know, is if someone is looking at purchasing a thing like this, is right now there may be a reimbursement, but you got to think of things like LipiFlow and other things that have come out before that were initially covered by insurance, and then that price got slashed, and then you're stuck with a $100,000 unit collecting dust.
Okay, let's move on to another topic here. I have a patient with vision affected by macular telangiectasis. Oh, I went the wrong direction. What's the latest and newest as far as management with macular telangiectasis?
So, how many have heard of Inselto? Very few, okay. You should know it because you'll be seeing it. The macular telangiectasia is a degenerative retinal disease. It affects the ellipsoid zone. It basically slowly destroys the EZ and photoreceptors. It has you can go to the next slide so I can it has this pathognomonic cavitations and ILM draping within the subfoveal region. Quite often we see this referred to us as AMD. Which it isn't. Sometimes even I have seen where retinal specialists have peeled ILM thinking it's a macular hole when it isn't. So the pathogenesis of macular telangiectasia is such that Mueller cells that produce one of the survival factors, CNTF, ciliary neurotrophic factor, they degenerate. Well, the interesting thing is Mueller cells are the ones that are also producing the factor, and the CNTF makes them survive. So Inselto is I'm not even going to say its non-trade name. It's revakinogene terversel. It's a it's a first-in-class encapsulated technology, cell encapsulated technology, and what it has, can I see the pointer, please? It is an implantable device. It has, I think I just went, it has a, it's about 6 millimeters device. It has a permeable membrane on the side, and inside it has RPE cells that have been genetically modified right there, and they secrete CNTF. The membrane permeability allows CNTF exit, but it does not allow anything to enter. And that makes it immune privileged device because the immune system does not recognize these RPE cells. So the way it is delivered, there's a small scleral incision, usually inferior temporal or inferior nasal quadrant. The titanium loop right here at the end is the fixation loop. We kind of thread 9-proline to that and fixate it to the sclera. We put the device in the vitreous cavity without doing vitrectomy, and then we close the scleral incision. The incision is about 3 millimeters. So what you might be able to see on these patients, when you dilate their pupil, you'll see that white capsule kind of behind the pupillary plane because it kind of points towards the nerve as you insert it. And you might see the incision, inferior temporal or inferior nasal quadrant, with some proline sutures tucked parallel to the incision. That will be blue, and some nylon sutures closing that. That will be your kind of telltale sign that that's the Inselto device in position. The data has been, it's been studied in over a decade at this point, but the most recent one, they had 2 clinical trials running parallel, and what it showed briefly that the CNTF delivery device decreases loss of EZ by 50% compared to sham. It was a very well-designed study. Sham arm was truly a sham where patients received a sham surgery, meaning they had incision, they had, just no device implanted. It is was approved March of 2025, so it's been on the market for a year. And like I said, you will see more of this, and it's extremely expensive. It's $250,000 for the implant. Insurances have been covering it. In some instances, they refuse to, or they want to see certain criteria met. Like, for example, they would want to see the ellipsoid zone loss to, up to certain square millimeters, 0.2. MACTEL patients lose 0.08 square millimeters of EZ per year. As a reference, subfoveal region is 0.2. So you can do the math how fast they can lose the vision and have photoreceptor involvement. So I'm very thrilled. All of us in the retinal community are thrilled to offer this treatment to the patients that slows down their vision loss. And right now they're actually looking into the regeneration of some of the EZ zone, because that's what we started seeing post-implant patients actually kind of regrow, or I don't know if that's realignment, because we know that the cell type does not divide, but maybe it's a realignment.
Yeah, I think I'm pretty excited about Inselto. My partner implanted one a month ago, and all of my retina partners, we've received training. We have a ton of MACTEL in the region that we're at. And I think the biggest thing, right, in looking at these patients is to target the ideal patient population. Like the example we have up here has pretty significant, subfoveal loss, where probably wouldn't maybe necessarily be the ideal candidate depending on their vision. But the whole goal is to try to get these people who have this slightly, extra foveal and target them early. And so, like you were saying, the cost is very high, and we've been trying to work. This company actually has great programs. They're willing to pay for product. They're being very friendly, but it really buy and bill and all of this through your surgery center. It's very technically challenging, but I'm really excited about this. And not only just for this specific drug with the neurotrophic factor, is the fact that they're already looking as a company to have other applications where they can put immortalized stem cell lines in, for example, to produce like anti-VEGF agents and other things like this.
Treatment of GA that we just talked about too.
Yep, which is awesome. And then I think the other thing is I was kind of laughing when we were kind of meeting with this company. They've been developing this product for a long time. And the story, the founder of this company, his son actually had MACTEL. And so he basically has a lot of blood and sweat equity into this. And that's why I think this technology is good. But my only criticism of it is, we've got a lot of injectables in the office. It's like, could we have made this a little bit smaller and just something we could have injected right in the office? But there's actually a huge manufacturing process for this. It's very detailed, and it's very delicate, so it's crazy.
Yeah. It's a good thing to add. CNTF has extremely short half-life, and they tried it. And it's not feasible because as soon as you inject it, it's gone. So that's why they had to have something that's constantly producing it.
Yeah, the only thing I would add is if there's a procedure you don't do often, you need to be doing it often enough to do it well. And we don't see it that much. And so in the Southeast, we send ours to Duke. We're not doing them in our practice yet, but that's because we also had some barriers with the hospitals wanting to procure it for us. I think now they're working so that we can get it through our office to do that if we wanted to. But yeah, if you're not doing it often enough to do it well, let people who do them do them. And so that's why we send those out at this point. It's a big expense. I think for the MACTEL people, picking the right patient who might benefit. The other thing too to consider is a lot of these people also have type 2 diabetes. And so sometimes I've got a guy that I follow for MACTEL who had noticed decreased vision, and we had talked about the Incelto, and he called and he said, I'm ready for the Incelto. I walked in there and was like, I'm ready to go to Duke. He had DME on top of his MACTEL. So I just treated the DME, and he had his blood pressure been up lately and stuff. So we kind of got that under control, and he's back to his baseline. So I'll factor in the concomitant diabetic disease in these patients, and then knowing who in your region are the ones that are doing this the most, because those are the people who are going to do it the best.
Yeah, one of the things, interestingly, in post-hoc analysis, they have found that diabetics are the patients who respond the best. They had most benefit as far as slowing down the EZ loss, which I was surprised. And the other good point that you bring, we do not know how it interacts with anti-VEGF. I have implanted it in some patients who get anti-VEGF for CNV, which those patients were excluded from trial. They have, if you had ongoing CNV and MACTEL, you could not participate. And I have yet to inject anti-VEGF because I don't know what it will do to the implant. Implant should be, it has certain criteria. For example, it cannot be exposed to air for more than 10 minutes. So, you know, we don't know what VEGF will do to it. Maybe it's something the company should test.
We have time for maybe one more question.
Indefinite. They have explanted those 15 years after implantation, and it was still producing the same amount CNTF as it was at the baseline. So that's the huge.
Thank you very much for your time and attention. We'd like to thank our panelists here, Dr. Hypes, Dr. Strand, and Dr. Sutherland. Have a great rest of your conference.